suppose patient is having fever or sweating, the demands will increase. Patient is connected to ventilator. So we should always remember, whenever there is increased fluid requirement, we have to see how much extra fluid we have to give. So fever will increase 12.5% of each 1 degree Celsius above normal. Similar with sweating and hypertension goes from 10 to 60% in cases. So how we sense hypovolemic state? This is very important. There are some signs and symptoms where we can find the patient is hypovolemic. If you see on the monitor, if patient has tachycardia, that is a pulse more than 100 or 110 beats per minute. The second criteria is hypotension or BP. If there is a low BP, systolic BP is ranging less than 90 mm HD. There are two most important signs which we can sense a hypovolemic state. If we see patients, we have a dry mucosal surface, or if it is, you can see the skin turgor, whether it is dry, skins or mucosa is dry. If we can see the crackling sounds in the lung, or the if a patient has invasive lines, you can see the central venous pressure, whether it is low, less than 6 centimeter of H2O. If you see the urine, whether urine is concentrated, whether the urine color is clear or not, and whether patient urine output is low, whether less than 0.5 ml per kg per hour. And we can see in case of patient with a diabetes insipidus, we can say the daily weight change, whether patient is gaining weight because of fluid retention or patient is losing weight because of the salt wasting. So as sir told in the first seminar only, that hypovolemia or hypotension must be avoided at any cost in neurosurgery. So as per the Brain Trauma Foundation guidelines, if we see even one episode of hypotension that is less than 90 mm HD doubles the morbidity and mortality. So any patients who has a brain insult, hypotension should be avoided in every cases. And for to avoid a hypotension, we should avoid a hypovolemia. So the brain trauma or a cerebral ischemia or a vasospasm will, what body will do? So body, what will do? Body will try to correct the things, correct the hypovolemia by increasing the intrinsic mechanism which body has, that is ADH, renin angiotensin systems, and aldosterone, which I described. So as soon as the insult happens, there is increased secretion of all these three hormones like ADH, aldosterone, and angiotensins, and they will go and work on the correction of hypovolemia. So body will try to compensate the hypovolemia by water reabsorption, by salt reabsorption, and by sodium and water reabsorption by aldosterones. So this occurs at a certain extent. If body mechanism fails to increase the hypovolemia or correct the hypovolemia, patient will have a called secondary insult. So whatever secondary insult happen in the brain is because of body, when body fails to correct the hypovolemia or hypotension. So to correct the hypovolemia or hypotensions, we should know what are the mechanism for a sodium and electrolyte or a fluid balance in the body. So to go to the evaluation and management of sodium balance in the body, we should know the basic concept of sodium hemostasis. As you see on the screen, there are 3 glass of water. Okay, one is maybe around 25%, one is a 50, and one is more than 75% filled with the water. Every glass has a 5 gram of NaCl, that is salt. If I ask a question, which glass, if you compare a 3 glass, which glass has a less concentration of salt? Which glass? Everyone will say last one, third one. But if you see the amount of sodium, amount of salt in the 3 glass is the same, 5 gram. So it is basically what's happening when you increase the water. Though the sodium remains normal in the body, but it will cause dilutional. So it will cause a dilutional hyponatremia. So in this condition, suppose a patient has a dilutional hyponatremia, by adding a salt will not treat the patients. It will either remain the same or it will worsen the condition. So what you should do is you should try and reduce the amount of water from the body. As soon as you remove water from the body, it will come to the second glass or a first glass and reach a normal stage. That's a basic concept of a sodium management. Now, to understand the sodium management, you should know the three terminology, that is osmolarity, tonicity, and osmolality. So, osmolarity Osmolarity is nothing but the concentration. Osmol is nothing but a solute, which how much amount of salt is present in a 1 liter of water. That is known as osmolarity. What is tonicity? Tonicity is, we all know, the cell membranes are semi-permeable. So the one side of the water and one side of the this jug, and other side, if you put a semi-permeable membrane, the semi-permeable membrane will allow only a selected solute to grow from this to that side. So tonicity is a concentration which is separated by a semi-permeable membrane. So if this side, you see, this side is higher solute, so it is hypertonic solution. That side is a low solute, that is, it is hypotonic solution. And how it is different from the osmolality? So osmolality, it is different. Only the difference between osmolality and osmolarity is the difference in the measurement. Osmolarity you measure per kilogram, where osmolality you measure by liter. So if 1 liter of water, how much osmol contains, it is a osmolality. It is a big equation which is written. I want to show the osmolarities depend mainly on the sodium and the potassiums. So if you have a maintained normal amount of sodium and potassiums, you will have normal osmolarity in the body. So to evaluate the hyponatremia, so as we see the hyponatremia, the normal sodium value ranges from the 135 to 145 milliequal per liter. If sodium goes below the 135, which we generally call as hyponatremia. So if we found a patient with a sodium value is less than 135, what should we do? So we see whether the patient is symptomatic or not. The symptoms for the hyponatremia ranges from the mild symptoms like a headache, giddiness, dizziness, to a severe symptoms like a seizures, drowsiness, or coma. So if patient has a severe symptoms, we have to treat hyponatremia irrespective of etiology and correct it fast. So irrespective of etiology or evaluation, start a hypertonic saline according to the calculations till the symptom resolves. Do not correct rapidly. Please do not correct the sodium rapidly, because rapid correction will lead to osmotic demyelination syndrome, and it is known as central pontine myelinosis. Suppose patient is relatively asymptomatic or has a mild symptoms. What do we do? So what we do is, as we told, we determine serum osmolality. So what is the osmolality of the serum? Suppose if find osmolality is a normal osmolality ranges from the 285 to 295 range. So is it around 280 to 285? So it is known as isotonic hyponatremia. The osmolality is normal, so it is isotonic hyponatremia. If we find osmolality is low, it is less than 280, so it is known as hypotonic hyponatremia. And if you see the osmolality is high, more than 285, then it is known as hypertonic hyponatremia. So based on serum osmolality, we have a three diagnosis of isotonic, hypotonic, and hypertonic hyponatremia. Now we come to the one by one. One is isotonic hyponatremia. Usually this is called pseudo hyponatremia because of the underlying condition of hyperproteinemia or hyperlipidemia, which will give a picture of hyponatremia. But the tonicity, the osmolality will be normal. Other condition is hypertonic hyponatremia. These are the conditions. Hypertonic hyponatremia occurs because of the excessive use of mannitol sometimes, or a radio contrast media, or a hyperglycemic stage, which will give you a picture of high osmolarity, because osmolarity depends on glucose also. So higher glucose concentrations, you will have a hyponatremia, which is causing hypertonia in the fluid. Very important condition is which we left is hypotonic hyponatremia. So hypotonic hyponatremia, how should we go? So when you know hypotonic, we should assess the fluid status of the patient. So there are various stages which I told. Either you have a CVP or a jugular venous pressures or a clinical assessment, and see whether patient is hypovolemic or not. If patient is hypovolemic, we usually assess with a urine sodium. Suppose urine sodium is more, it is more than 20, means renal is losing the sodium, means patient is actively losing the sodium and the water, that's why it is hypovolemic. This kind of patient will respond to isotonic saline, and we have to replace as a 1:1, 1% of fluid along with the 1% of sodium, both have to replace adequately. This is the condition known as cerebral salt wasting. Second condition, when urine sodium is normal or less. Urine is kidney is not losing sodium. Then why still patient has hypovolemia? In this condition, patient is not taking feed, insufficient intake, or patient has vomiting or diarrhea or GI loss. This kind of condition, patient has hypovolemia and hyponatremia because of the either vomiting, diarrhea, or insufficient intake. So just replace the intake is a treatment. What if you find a euvolemia? You see the hyponatremia, but patient volume status is normal. There is no signs of hypovolemia. Again, you check for urine osmolality. Suppose you find a high osmolality in the urine, means urine is concentrated. Urine is high, have a high more osmolality. Urine is concentrated means someone is absorbing water. Who is absorbing water? It is ADH, which is absorbing water. So in this condition, which are known as SIADH, syndrome of inappropriate ADH secretion, where ADH is more. That's why the urine is concentrated. Or there is a thyroid or cortisol insufficiency, which is causing this kind of picture. In this condition, the sodium level is normal, but because of water, excessive water, there is a dilutional hyponatremia. The treatment for this is fluid restriction. So you restrict the fluid, the water will come down from the body and sodium will become normal. What if you see the urine osmolality is normal? Patient is euvolemic, urine osmolality is normal. Means urine there is no concentrated urine. So ADH is not there, but patient is normal. Patient is euvolemic. Patient is also not hypovolemic. That means it is it is a condition called as psychogenic polydyspepsia or primary polydyspepsia, where patient is drinking more water and telling drinking more water and diluting the sodium, or patient has a low salt intake. There are two conditions. So when urine osmolality is normal or less and patient is euvolemia, again you can tell the patient to drink as per the thirst. It is known as treatment is fluid restriction. And what if you find the patient hypervolemic? So hypervolemia means it is because of fluid retentions. So basically, these are condition which is related mainly to the medical conditions like a renal failure, nephrotic syndrome, or a congestive heart failure, where you need a treatment with the fluid restrictions, sodium restrictions, along with the diuresis. So we describe a condition with the case. So if you see elderly lady came with the slip and fell at the home, CT head you did, and you find a bilateral frontal contusions, and you are going to manage it medically because it's not a surgical advice. And day three of admissions, you find a patient, you just you going and see the patient condition. Patient you find a euvolemic. It is patient is euvolemic. Okay. And these are the lab values. Morning lab values we have sent. Serum sodium is 123. So doctor has told to see send all profiles. So serum sodium is low. Serum osmolality is 257. It is low. Urine osmolality is high. Urine sodium is high. Thyroid cortisol is normal. How will you interpret this? Serum sodium is low. Serum osmolality is low. So serum osmolality low is some water is coming in the blood and it is making salt concentration low. That's how you interpret. Urine osmolality is high. Means urine, somebody is there which is pulling the water from the urine. That means who is there? ADH is there. So basically, it is a high secretion of ADH which cause this kind of picture. So where the graph goes here. Euvolemia, urine osmolality is high, thyroid and cortisol is normal. So it is a condition known as SIADH. So any intracranial insults which can cause release of ADH from the posterior pituitary, and ADH, as I told, act on collecting ducts and really absorb the water. So if LDH is reabsorbing water, extra water, why there is euvolemia, not hypovolemia? So there is a reason. So when there is an inappropriate ADH release, what will happen? More free water from the collecting ducts go to the blood. That will cause increase in intravascular volume. Intravascular volume will cause cardiac filling. Cardiac filling will cause release of atrial natriuretic peptide, ANP. This ANP is a natriuretic peptide. So it is going to tell the kidney to lose the sodium. So there is maybe some amount of sodium loss occurs along with the fluid in renal system. That's why there will be a balance in between. So that's why in case of SIADH, you will have a high concentration of urine sodium. So what you will do for a treatment, you will restrict the fluids, you give a salt tab as an adjunct. If you have a severe hyponatremia, you give a hypertonic saline. Okay. The 5 minutes. So case two, it's a simple case, similar case, But you see patient is hypovolemic on assessment, patient is refusing the meal, and if you see the serum sodium is low, osmolality is also low, urine osmolality is high, urine sodium is low, except urine sodium is high, here it is low. So what do you think? Patient is not taking meals, means patient is having a insufficient intake, just replete the fluid. One more case, if you see same patients, if you find poor turgor, dry mucous membrane, but if you see the IO chart, there is a 2 liter of urine lost over last 12 hours and with a negative balance on IO chart. And if you see the osmolality and the serum sodium, here urine osmolality is significantly high, 523. Urine sodium is significantly high, 110. Means patient is losing sodium. Patient is losing sodium in the urine, that goes to the cerebral salt wasting. Hypovolemia because of the salt wasting. So what is cerebral salt wasting? Brain insults will cause a similar way releasing BNP. BNP will tell kidney to lose sodium and along with the water. So there will be overall hypovolemia and hyponatremia. One more entity is hypernatremia. Hypernatremia is nothing but the serum sodium which goes more than 150. Because of lack of time, I will skip the calculations. We can calculate total body water with these equations, and similar way, free water deficit we can calculate with this water. Directly, we can go to the case. The case is a 40-year female, 50 kg weight, operated case of non-functioning pituitary adenoma. On PODV1, you see the urine output, it's coming 300, 320 ml over last 2 hours. And if you see the lab value, you have a high serum sodium, high. Serum osmolality is also high. Urine osmolality is less. There is no concentrated urine, and urine sodium is normal. High serum sodium, high osmolality means there is high solute concentration blood, but low solute concentration urine. The condition is known as diabetes insipidus. Diabetes insipidus occurs because of the low level of ADH. So you have a high amount of diluted urine, often accompanied by the craving of waters. And if you don't treat, there is a danger of severe dehydration. So what is central DI? Central DI occurs because of the after transvenous surgery for craniopharyngeal and pituitary adenoma. You have a transient DI, means you have a for 2 or 3 days you have a supranormal urine output and polydyspia, which typically normalize because of the little bit insult to the pituitary stalk. Sometimes you have a prolonged DI when you have damage permanently a pituitary stalks or a craniopharyngioma, which known to damage the pituitary stalk. This kind of patient will have prolonged DI. Urine output stays supranormal for sometimes years or from lifetime, and patient needs a lifetime replacement for ADH. And the third category of patient which shows a triphasic response. So initial for a 4 or 5 days, you have polyuria phase when patient has a low amount of ADH because of the direct injury to the stalk. So patient will have a polyuria, and what will happen after 4 or 5 days? Residual cells which has ADH will secrete come into the blood. So you have unregulated. There is no pituitary stalk. So unregulated secretion of ADH will cause transient SIDH features that is known as antidiuretic phase. And once the stored ADH gets over, you don't have ADH at all. Then the patient will go into the polyuric phase that is known as permanent DI, third phase. How will you diagnose? As I already told, high urine output, normal ribosodium, normal adrenal functions, or inability to concentrate urine. That is a diagnostic criteria for DI. Treatment of DI, if there is a mild DI and patient is intake thirst, tell the patient to drink water as per the thirst. And if patient has severe DI, according to calculation which I showed, you have to replace fluid orally, intravenously, or you can give a vasopressin analog. These are the vasopressin analog which is available, which commonly known as pitricin, that is intrinsic peptide, and desmopressin, which is oral tablet, or intranasal, that is minerin. Pitricin is a short acting, and minerin is a little long acting. And dose for pitricin is 1 unit per kg, and desmopressin usually we start 0.05 mg orally twice a day. This is the last case, 48-year female, 50 kg, operated case of non-functioning adenoma. Immediate post-operative assessment, urine output is 250, 270 ml per hour. But if you see, everything is normal, except there is mild elevation of serum osmolality. Do you consider this is a diabetes insipidus? No. What we should take care always in mind is post-surgery fluid immobilization. Though the patient is operated case of pituitary adenoma, intraoperative balance because of the blood loss, giving the fluid, there will be post-operative fluid mobilizations and excessive fluid will be thrown into urine. That will lead to sometimes significant diuresis from the next 12 to 24 hours. So we should go by the assessment and serum sodium, not by the output. To summarize, we have SIADH, this is eumolemic hypotonic hyponatremia, high urine osmolality, treatment is fluid restriction. Salt wasting, which is hypovolemia, hypotonic hyponatremia, high urine sodium and urine output, isotonic saline replacement, 1 is to 1 is a treatment. DI, which has high urine output, hypertonic hyponatremia, disproportionately low urine osmolality, drink to thirst, and if unable to compensate, give vasopressors. Thank you.
Thank you very much, Dr. Pavan, for this enlightening lecture. The next speaker will be introduced by Dr. Parmeshwari. Any questions in the audience will be taken at the end of all these three talks.
Now I introduce the next speaker, Dr. Kalpalata Guntapalli ma'am, currently Professor and Chief of Pulmonary Critical Care, Sleep Session Bentop Hospital, Director of Critical Care Fellowship, Baylor College of Medicine, graduate of Osmania Medical College, trained in pulmonary disease at Georgetown University, Critical Care Medicine, University of Pittsburgh. Area of interest is ARDS, acute severe asthma, and mechanical ventilation. Achievements are member of Critical Care Board of ABIM, President of AAPI 1999, President American College of Chest Physicians, recipient of Pravasi Bharatiya Saman Award 2012, Parker J. Palmer Courage to Teach Award, World Lung Health Awards by ATS, Distinguished Scholar in Critical Care by ACCP, and Presidential Award of Academic Excellence by Baylor College of Medicine. I request ma'am to kindly come and deliver a lecture on tracheostomy, troubleshooting in a tracheostomy patient.
Om Sri Sai Ram. Good morning. I want to thank Pankaj Puneta for inviting me again. This is our 6th or 7th year coming here. I thought I will do this topic of tracheostomy, care of tracheostomy patient, just by going through few cases because we can't cover the whole topic. So I'll just talk about challenges in the care of tracheostomy patient. So we'll make this case-based discussions of complications of various stages of tracheostomy and various acute, subacute, and chronic patients. So basically, the complications are common to all types or all durations of tracheostomy, and acute generally defined as tracheostomy of less than 7 to 10 days duration. Then mature tracheostomy is considered after 7 to 10 days. And then, somebody could be having tracheostomy for years or months, and post laryngectomy situation is different. So, from now on, we'll have probably 6 cases, and I would like audience participation. So, this is a patient on a ventilator is experiencing distress. He just came back from tracheostomy an hour ago. Respiratory rate is 40, pulse rate is 120. He's on spontaneous, so he's breathing large volumes. FiO2 is 0.7, PEEP is 5, peak pressure is 60, plateau is 40, which is much higher than what it was before. What is the most likely cause? What do you think is the cause? And I'll show you the X-ray. What do you see on the X-ray? White or black? That's all you have to know, white or black. So is it white on the left side and black on the right side, right? So should it be white on the left side? Left of the patient? No? So where the lungs should be, where the black should be, it's white, right? So what causes that? So is it pneumothorax? No, because it should be black, right? So, um, what about, is it lung collapse? Yes, could be, right? So, when lung becomes airless, it assumes a water density. And you can see that the mediastinum and the heart are shifted to the left side, right? Is it secretions? Possible. Secretions could have caused lung collapse. Is it blood clots? Possible. We don't know. So, what if? How do you know if this is not pleural effusion? Can you tell if this is a pleural effusion? If your pleura was full of, let's say, 2 or 3 liters of fluid, it will still give white shadow, right, instead of black. If this pleura was completely, does this work? If this was full of fluid, this is because of pleural effusion, you would have seen that the mediastinum would have been shifted to the other side, or at least it would have been in midline. Here you see that um, it's shifted to the left side. So it's pulled to that left side, which means there's some volume loss. So this looks like it's a lung collapse, the cause of which, because this is a patient just came back from surgery, so it could be the secretions or blood clot, right? Your lung collapse is correct, secretions possible, and blood clots, both of them as a cause of lung collapse. So this patient, this is what was found on bronchoscopy. You can see that this is actually how it was sitting. So it was left main from the main carena, left main stem bronchus. Yeah, left main stem bronchus, and this part is left main stem bronchus, and this is going into one of the lobar segments. So this is a blood clot that was completely blocking the lung, causing collapse. Okay. So that is one of the common causes of patients, complications of any stage, but mostly acute or subacute. Um, this is a patient with 60-year-old with increasing shortness of breath. So what do you see on this side, white or black? White, which side now? It's on the opposite side, right? So you see this whole side is whited out, and left side is normal or not normal? Hmm? Yes, no? Left side is also not normal. You see the heart shadow, but there's a lot of infiltration here, right? In the lower lobe, but rest of the lung you can see here. So this is also similar situation that you have a whiteout on one side of the lung. And this actually was a case on 28th. I don't know if there's a date, 28th of December, just before I was starting. This was one of the patients presented like this. And what was done, you can see that this patient was actually intubated and bronchoscoped, and you can see that about 4 or 5 um, bottles of very thick, large yellow sputum was suction. This patient was tracheostomized, and 2 days later, he nearly arrested. Um, and the same issue. The guy has no cough reflex, and he just wouldn't cough. So same situation. Even after tracheostomy, patient has same large amounts of secretions that need to be suctioned. So this is one of the common problems. And generally, I would say it's mostly on the left side, even after tracheostomy or intubation, not so much on the right side, because when you put a suction catheter, the right main stem is in the main line of after the carina. So you generally end up suctioning the right side and not so much the left side. So most of the time, it may be a left lung or left lower lobe collapse that we see. Okay, this is a second case. 35-year-old patient is in the ICU 6 hours post tracheostomy. Oxygen saturation 60%, and the tracheostomy tube came out. Okay. So what will you do as a next step? Okay. I like your participation. Try to place the tracheostomy tube back into the lumen. Yes. How many would vote for that? You can raise your hands. It's okay. I'm the only one seeing, so your colleagues are not seeing. Okay, suction through the lumen. of the tracheostomy opening? Yes, no? Bag mask ventilation from above? Intubation from above? How many? Vote for it. Don't be hesitating. Whatever you do, be confident. Place oxygen mask via the tracheostomy hole. Put a mask and ventilate. Anyone voting for that? No? Okay. What is the problem if you try to put the tracheostomy tube back into the lumen when the track is not mature? Very important. You can have a major disaster on your hands because you can create a false track anterior to the trachea, especially if it's less than 10 days. This patient is just 6 hours post trach, right? So you never try to put the tube back in unless ENT who did surgery or whoever did surgery is there. Even they would hesitate unless they're sure that it's not going anterior to the trachea. I've seen many patients die because of just trying to attempt this. Okay, suction through the lumen, all of those are. So what is the alternative is, since the patient still has larynx, we try to intubate from, if the patient, like I mentioned, has saturation of 60% or something like that, patient is crashing, you still have the upper airway intact, right? So you intubate from above and make sure that the cuff is below the trach side. So the air is not leaking out from the, and then you can take your time to replace or, the trach, and you at least save the emergent situation. So that would be the thing. Bag mask ventilation, if we have to do, we have to close the trachea, close the stoma with the claws and fingers, and then try to bag from above before you can get ready to intubate the patient. Okay, so anybody differ with that management or anything? No? So most important, sometimes they'll have stay sutures on the trachea to pull it forward. But if it's the middle of the night and there's nobody available, and the safest bet is just to intubate from above because the larynx is still intact. Okay, this is a 50-year-old patient who had tracheostomy 2 weeks ago. He had bleeding from the trach side 20 ml the day before. Now the nurse calls you with sudden, brisk, bright red bleeding. There's a lot of bleeding. 2 days ago, there was like a 20 ml of bleeding, and now it's a lot of bleeding. So, what is the most likely cause? And how would you manage it? Suction induced mucosal trauma, because you've been suctioning for 2 weeks. Maybe you damage the mucosa and the patient is bleeding. Anybody will go for that? Yes? No? It's actually quite common, but would you have 20 ml and then massive bleeding? Yes? No? Nobody's going for it. Tracheoinnominate fistula, how many are going for it? Raise your hand. Okay. GI bleeding aspirated into the lungs that you're suctioning? No? Actually, it's possible. Not 20 and bright red blood. I have seen so many times nurses will call you that there's bleeding from endotracheal tube, and that's how you pick up GI bleeding, because the stomach may be full of a liter or liter and a half of blood, and it kind of regurgitates, goes into the trachea. But I think bright red and unlikely. Bleeding from granulation tissue? Possible? Granulation where? Because I think to recognize this particular problem is very important in how you're going to manage, and how much of a red flag or red light you're going to escalate. Okay? Okay, this is actually called a tracheoarterial fistula. Most of the time, the artery that usually it's a tracheostomy tube tip or the cuff that erodes to the anterior wall, and it erodes into a vessel. So it's called tracheoarterial fistula, but most of the time it's the tracheoinnominate fistula. So one of the causes is that either it's a low lying trach or a high riding innominate artery. So either you did a low trach or high innominate artery, so it has a chance to erode and cause massive bleeding. So 50% of these patients have a warning or sentinel bleed. So you'll have like 20 ml or 30 or 40 ml of bleed, very bright because it's arterial bleed, and then they'll just open up. How many of you have seen this? Has anybody seen this? I'm sure Dr. Chalam has seen. You have seen. You have seen. You have seen. Yeah. I mean, obviously, I've been doing this for 40 plus years. Maybe I've seen 4 cases. How many survived? 2 survived. Okay. So it's actually the survival is very low in the literature. It's about 14% or something. So it's very low. So once you see this, because it's an arterial bleed and patient will asphyxiate, so this is a very drastic situation. So if you see it, what you need to do is you overinflate the trach cuff, even 30, 40 ml, and then you insert the finger the suprasternal notch and try to compress the artery. If that doesn't work, then you insert your finger behind the sternum and try to compress the artery between your finger and the sternum. And you take the patient like that. If you are able to control the bleeding, you leave your finger there until the patient goes to the operating room. Okay, so that's how you transport. And the only one I know, and the last one that survived it was recognized, although it was middle of the night, recognized, it was picked up, somebody did immediate intervention, somewhat control of bleeding, and the patient had immediately gone to the operating room and got the vessel ligated. Otherwise, mortality is extremely high. So what is the lesson here? It's not very common. Probably you may see 2 3 in your entire career. The important thing is still the patient you can give a chance. We have to recognize. So first time you have 20 ml bleed, you just have to think about it. Could this be going on? So you're alerted next time you have a very large bleed. Okay. So very always this should be at the back of your mind. Okay, a 60-year-old man with history of surgery for laryngeal cancer 5 years ago is admitted with bleeding from the site and in respiratory distress. His oxygen saturation is 70%, and the neck exam is shown below. Attempts to insert the trach tube are unsuccessful. So you all see what we see in the neck, right? So what should be the next steps? The guy is in distress, saturation is going down. What should you do next? Insert catheter and suction. How many will go with this? Insert a suction catheter into the lumen. Insert endotracheal tube from above, from mouth. How many will do? Insert a tracheostomy trach tube over a fiber optic bronchoscope. Yes, I see 2 hands. Back mask through the opening. Okay, it is a disaster if you try to intubate from above. Why? There is no larynx. That's very, very important. So, what is the difference between tracheostomy and tracheostoma? Tracheostomy is the larynx is still intact, and stoma is basically trachea is brought to the skin as a stoma, no longer has any communication with the oropharyngeal cavity, right? So, so when you look at these, this is the. Do I have 5 minutes or 10 minutes? So this is the larynx, is the normal neck, and this is a patient with tracheostomy. So you just made an opening into the trachea, but still nasopharynx and all of this is intact. Your larynx is intact. When you have laryngectomy, this is a blind pouch. There's nothing. This is only going into trachea and lungs, and there's no communication. So if we try to intubate from above, it's a disaster, right? Because there is no communication. So we, in our place, we use these if a patient with laryngectomy, previous laryngectomy, and just comes with a stoma, we always put this on the door and at the head of the bed, that you don't try to intubate from above, and it always comes with a pack of size 6 endotracheal tube and few things that you need if the patient comes into trouble. And we've had a couple of near disasters, people not recognizing that this is there's no larynx from above. So seems simple, but if people don't know the history or are not familiar, this can be a disaster. So we always post this as soon as the patient gets admitted. Okay, 40-year-old patient has mechanical ventilation for 3 weeks post-trauma, was decannulated, and there's inspiratory stridor. What is the possible cause? Mucus plugs, croup, tracheal stenosis, tracheomalacia. I don't know if it's playing. This is actually subglottic stenosis. And I don't know, the picture is. So this is a flow volume loop that kind of shows what they call envelope shaped flow volume loop, or both inspiratory and expiratory obstruction. And oh, so you need to be very cognizant of tracheal stenosis in patients. I don't know, it got stuck or something. Okay, so this is okay. There is a video that went with it. So okay, that's okay. Never mind. We're out of time.
And touch this one for slideshow.
Okay. Why is it not? Is it frozen? Let me just. It's coming. Okay. So that is tracheal stenosis. Okay, this is the last case. 40-year-old man has been discharged after prolonged ICU stay for ARDS. His trach tube was decannulated 2 months ago. He's admitted with cough, syncope, and recurrent pneumonia. This was the X-ray when the patient was in the hospital. Okay, do you see anything that's striking? This tracheal stenosis, tracheomalacia, vocal cord dysfunction, or reduced immunity. Why he's getting repeated, and cough syncope. You can see that the cuff on the tracheostomy tube is very wide, and this is actually tracheomalacia, which is basically a cartilage that is destroyed. You can see that this is, and this is the bronchoscopic findings. You can see that the trachea is here. This part is like a cave. This is where the cuff was. So this is all destroyed anteriorly. So you have anteriorly, there's nothing holding the trachea to keep it open. So every time he coughs, he has syncope because they approximate anterior and anterior wall of the trachea is what keeps you from um, collapsing your airway. When we cough, our velocity is 2/3 that of a sound. So we don't pass out when we cough. But if you have nothing holding the anterior, you can pass out. So basically, you can have tracheostomy complications on a chronic basis or in a subacute is you can have stomal stenosis from cicatrix or granulation, or you can have at the level of the cuff, tracheomalacia, or stenosis, or the level of the tip. You can have stenosis or tracheo arterial fistula and so on. So in complications of tracheostomy, in summary, you have common to everything is bleeding, secretions, mucus plugs, less than 7 days bleeding, lung collapse, subcutaneous emphysema, pneumothorax, not very common. Mature trachs, it can be bleeding, mucus plugs, dysphonia, aspiration. And then you think of tracheomalacia, tracheal stenosis, tracheoinnominate artery fistula. Post laryngectomy, there's no larynx, so you cannot intubate from above. And phonation is only by directing air into the esophagus. That's all I have. Thank you.
Thank you very much, Kalpalata madam. Are there any questions from the audience at this point? Madam, I would like to ask one question about this tracheoinnominate fistula that you mentioned. If we see sentinel bleeding, should we investigate the patient at that point of time, because it's a very disastrous course expected thereafter? So, vascular surgeons. Okay. So if we see a significant amount of bleed through a tracheostomy, so sure. Hmm.
So it's not like what you would see normally.
Yeah. Okay. Thank you so much. We'll move on to the.
Ma'am, when we get bleeding from granulation tissues, like when tracheostomy, how do you manage it? Like, you have to suck this patient and this granulation tissue just below. So how do we manage once a granulation?
Granulation tissue, you can cauterize it, and if it is tracheal stenosis, which is very flimsy and like a strandy or flimsy, they can actually do radial cuts and dilate. Granulation tissue, if it's very long, then they'll have to resect if it's tracheal stenosis. Granulation, usually you can manage by cauterization and things like that. Interventional people will.
Now I introduce our next speaker, Dr. Adi Nadimpalli sir, Internal Medicine Pediatrics. Since 2005, Dr. Nadimpalli sir has served as an MSF field worker in various capacities, from field doctor to medical coordinator to head of mission in over 10 countries. Vice President of MSF USA Board of Directors, undergraduate degree at UCLA, and internal medicine program Tulane Medical School 2001 to 2005.
It's okay if I have a small reward for people who answer questions. Sure, it's okay. Sure. You can start speaking. Um, Good morning, everybody. Thank you, Dr. Pankaj and Dr. Guntapalli, for inviting me to speak here. It's my first time here. It's quite a fantastic institution. It's very impressive. As per the introduction, I've worked in global health for more than 15 years now in different parts of Africa, South America, Middle East. And I'll talk a little bit about that, I think, later today. Um, but as our first speaker, Dr. Chalam, was talking about, nurses are incredibly valuable, especially when we do multidisciplinary rounds. And in all the hospitals and all the clinics I've worked in, um, having a good nursing team makes the most difference for patient care. The ability to anticipate problems, the ability to carry out procedures, discuss with the families when they're at the bedside all the day, and really do a lot of things. So this talk is really geared towards the nurses. Dr. Guntapalli I think, was getting everybody involved and answering questions. I'm going to take it even one step further. And for people who have actual answers or involvement, I'm going to give a treat. So these are not really hard, but even if you're wrong, just try it and I will try and give you a treat. Okay? So we're going to talk about electrolytes, and electrolytes are a huge subject, and we've already had one discussion about hypernatremia and hyponatremia, which was fantastic. One of the main things to know about electrolytes is if you're starting to chase them, you're already behind. Anticipatory care of electrolytes can make a huge difference, and we'll talk about some of these things. So the first case, this is all case-based discussions. So we have a 24-year-old female with polyuria, polydipsia, and weight loss. We see her glucose is elevated, her potassium is 2.9. So maybe just as first simple questions, what do we think is happening to this patient? And what are some of the first steps you would do to treat? especially nurses, if you want to answer, you get Snickers bars. Yes. Who said? Yeah, so it's diabetic ketoacidosis. That's not, I mean, we can check our acid base status and our beta hydroxybutirates, but it's diabetic ketoacidosis. So, what are the first steps you would do for this patient? What's that?
Correction of sugar and correction of potassium.
Okay, sorry. Sorry, ma'am?
Correction of sugar and correction of potassium. Potassium should be corrected because potassium is 2.9, it's low, and glucose also, sugar also should be controlled.
No, that's 100% right. And this is a very dangerous thing in DKA is to treat the sugars first before correcting the electrolytes, especially potassium. Because here, what will happen is the insulin will make the potassium go even lower, and then you can have pretty significant problems with hypokalemia. And so the normal treatment would be to give IV fluid, to give potassium replacement, especially IV, because these patients are normally unable to take anything PO. So you would try and give it, if you have, most of these patients will have peripheral IVs, and so you can only give 10 milliequivalents per hour through a peripheral IV. And so you either do 1 or 2 different peripheral IVs, but you try and get their potassium at least to 3.3 before starting insulin. And the risk of hypokalemia is arrhythmias, and that's the main risk. And you can see the EKG progressions here. You see initially the T wave shrinking, but then you get a really prolonged QT and a U wave that comes up, which can morph into ventricular rhythms. You can also get, with hypokalemia, pretty significant weaknesses. Weaknesses which may cause rhabdomyolysis and kidney disorders. So anytime you have somebody with hypokalemia, the first order is just to recheck it. But as you recheck it, always check the magnesium also, which coexists with the potassium. And then, as we said, if possible, it's always better to treat orally. But if you have to, you can give IV. And trying to give IV peripherally is obviously slower than giving it by a central line. And if I understand correctly, you have a lot of potassium protocols here. Okay, I think those are pretty common in many of the ICUs across the world. And this helps part of that to ensure that we don't fall behind in electrolytes, so that somebody who's writing a prescription hasn't seen the laboratory value and taking time to write the prescription, but the nurses are able to take initiative and give the potassium earlier on. Okay. So second patient. It's a 45-year-old male in the cardiac ICU who has minimal urine output. You see the EKG below. So maybe 2 questions. What are some of the abnormalities on the EKG, and what do you think is happening with this patient? Oh, it's not very clear. Yeah, so whoever, maybe you can help me find out. Hyperkalemia is completely right. And what are some of the EKG changes, or at least the main one that you see on here? Yeah, you see really peak T waves, but you're also seeing kind of a widened QRS and a kind of an abnormal QRS morphology also. And this is really a harbinger of badness for this patient. So as with most electrolytes, if you find an abnormality, especially one that you don't believe, just recheck it. But in this patient, you probably want to treat before you wait for the second lab to come back, because you have the other part, not just the laboratory value, but you have an EKG that shows pretty significant abnormalities. And so there are temporizing measures that you can use. The best one that causes cardiac cell membrane stabilization is the calcium gluconate. 1 gram or 2 grams. And you can use calcium chloride, but again, that is a little bit more powerful. And if you have a central line, it's easier. You can also use insulin, 5 units, plus giving, I'm sorry, plus giving glucose if the patient is normal glycemic or hypoglycemic. You can give albuterol, and frequently people give just the 1 dose of albuterol, the 2.5. What you actually have to do is give large doses of albuterol, so up to 10 milligrams or 20 milligrams. So it's almost a continuous nebulizer. But these are all temporizing. Eventually, you have to eliminate the potassium, and to do this, you need loop diuretics. If the patient has end-stage renal disease and oliguric, of course, this will not work. You can try oral cation exchangers. They do work. There are complications with those, especially the older ones, because they do cause ileus and necrosis of the bowel. But the final answer always is dialysis. And if the patient has postoperative complications, if there's some other problem, this is the thing that will improve the hyperkalemia. Okay, so we go to our next case. 35-year-old male with alcoholism and malnutrition who's admitted to the ICU for severe pancreatitis and severe ARDS. He was intubated. By day 3, enteral feeds are started. And by day 5, he's starting to get better, and the team thinks they can extubate him. However, every time they try and extubate him, the patient is awake, alert, is passing the spontaneous awake trials, but is not passing the spontaneous breathing trials because of tachypnea. Why? Yeah, so there's absolutely, obviously this is a discussion on electrolytes, so guessing electrolytes is the best idea. But really, this is refeeding syndrome, which is both the magnesium and a phosphorus problem. It's the high-risk patients are those who are already underfed, at least for 7 days, who have malnutrition. And it's caused by early feeding at higher levels. Clinically, patients have encephalopathy, delirium, and the main issue that we're talking about in this patient is weakness. So this patient likely has diaphragmatic weakness and is unable to take proper tidal volumes and becomes very tachypnic, and so the team is unable to extubate him. So what you end up seeing in these patients is hypophosphatemia, hypomagnesemia, and hypokalemia, all which cause weakness. Okay? So you can actually try and prevent these. And a lot of times the prevention and the treatment are very similar. So obviously any patient that has alcoholism, you would like to give thiamine right away. And sometimes in patients who have alcoholism and some evidence of Wernicke's or some evidence of encephalopathy, maybe you want to even try higher doses of thiamine, B12, folic acid. So in these patients, you might want to try starting feeds a little bit slower. In pancreatitis, the latest literature is to start feeds earlier than later. But in these patients, you might want to try at a slower rate. And if you already think that these patients have refeeding syndrome, you want to cut their feeds down. And then obviously, you want to aggressively replace their electrolytes, phosphorus, potassium, and magnesium. This one can't see very well. This is a patient I took care of last week. No, Dr. Narendra does not get a chocolate. I know she is not a nurse. So this is definitely torsades. Okay, so in speaking of electrolytes, what do we think would be the electrolyte deficiency in this patient? Absolutely, it's magnesium. Right, so this is a polymorphic ventricular tachycardia, and the difference between that and just regular polymorphic ventricular tachycardia and torsades is also the QT interval, so the prolongation of the QT interval. Obviously, if the patient that I took care of it was a lithium toxicity with acute kidney injury, but the patient ended up on the medical ward being treated for lithium toxicity and getting hydrated, but ended up in that rhythm. So we ended up having to do, we had to shock the patient once, And then with magnesium, the patient responded quite well. We ended up continuously dialyzing the patient even with the normal potassium because of the lithium. In the United States, we have toxicology control, and they give us recommendations, and they recommended dialyzing this patient. Okay, we have two more cases. So we have a 75-year-old female who recently started a thiazide diuretic and now has an acute seizure. So let's take the broader picture and ask, what are some of the electrolyte abnormalities you could see in patients with seizure? That's the first question. And the second question, what do you think is specifically happening to this patient? So the first question, just generalized seizures. Absolutely. Sodium is a huge one. What else? Yeah, calcium, absolutely. Hypocalcemia. One that's unfortunately I don't know if anybody said it, so I apologize, but one that's frequently missed, but may or may not count as an electrolyte, but should be checked right away for anybody who has a seizure. Somebody said sugar. Right? So that's something at the nursing level, we can just check at the bedside right away. It's a very simple thing to treat. We see that frequently in many settings. I saw that frequently in patients with malaria. So in sub-Saharan Africa, a lot of children end up with malaria and are hospitalized for that. Frequently, they have sudden death. We suspect it's because of hypoglycemia. Frequently, also, they have seizures. The malaria itself can cause seizures, but the malaria parasite can cause hypoglycemia. And very frequently, just giving glucose and then measuring the glucose every 30 minutes until they have sufficient normal glycemia obviates the seizures and helps these children survive. But away from the glucose, so now we're going to talk about other causes. So we talked about hyponatremia, hypocalcemia, and other ones are hyperammonemia, uremia, and phosphate. So we talked about hyponatremia, and I wrote here a very complex subject, but I think we had a really great discussion on it, so I think we don't have to go into that. But really, the very simple way to think about it is just too much water for the amount of salt. And we already talked about fluid overload states, which is congestive heart failure, cirrhosis, and renal failure. Euvolemic states, especially SIADH. And then hypovolemic states, cerebral salt wasting, chronic vomiting, or diarrhea. So if you had a patient with a seizure and hyponatremia, what would you give? I think somebody's saying. Yes, we give just 3% normal saline. The 3% hypertonic saline. The idea is just to increase your sodium by 4 to 8 milliequivalents or millimoles per liter. Just doing that decreases the seizure threshold and decreases the seizures for these patients. Frequently, we end up giving 100% milliliter boluses, at least 1 or 2 until the patient recovers. And we had talked about earlier today, for SIDH, you would want to do fluid restriction. For loop diuretics, help decrease the amount of sodium in the blood. Thiazide diuretics do the opposite. Urea is very popular. DDAVP can be used to slow down the rate of increase. And the maximum amount, it's been decreasing over the years. Years ago, it used to be 12 milliequivalents per day, and then it came down to 10. And now it's almost 6 to 8, so that we decrease the risk of long-term problems. And then the final case. So we have a 55-year-old female post-cardiac surgery with delirium. And we used the CAM ICU score, and we found that she has delirium. What are some of the common causes of delirium? Yes, absolutely. Any types of withdrawal or intoxication. What's that?
Long stay.
I didn't hear that very well.
Prolonged ICU
Yeah,
stay.
prolonged ICU stay. Medications that we give in the ICU, especially benzodiazepines, which we try not to give. All of these things, but in the spirit of this discussion, it's in this patient. So it's medications that we give. Any type of medications can give it. Some antibiotics, such as cefepime, withdrawal intoxications, fever can cause it, pain, urinary retention, and electrolytes, especially hypernatremia. And it's these last three that I want to touch on for a second. Especially somebody who has delirium or ventilator dysynchrony, a lot of times we in the ICU want to just give the patient more sedation because we think they're not doing well, they're delirious, let's just give them sedation. But pain is a frequent cause. So if we actually treat their pain, they'll become less delirious and more synchronized on the ventilator, and we have a greater chance of extubating them on time. Same with urinary retention. It's very frequently that you put an ultrasound or on the patient's bladder who doesn't have a catheter, and it's quite large, and the patient is just uncomfortable. And so this last thing, the electrolytes, especially hypernatremia, is a very big problem. Patients with hypernatremia, and this is I think the last question for me. Do you know what is the bad feeling somebody gets when they have hypernatremia? Sometimes confusion, but it's thirst. Patients get really. Somebody said it. Okay. So it's excessive thirst, and we don't really pay as much attention to it as we should. But imagine being parched, and I myself am parched, so thank you for the water. But imagine just your mouth is dry the whole time, you're intubated, or you're in an ICU and you're not able to communicate. It's a terrible feeling. And these patients suffer, and then they become more confused and more agitated. The easiest way to take care of this is just to treat the hypernatremia. We talked about diabetes insipidus earlier. One of the most common causes of hypernatremia is just inadequate free water, whether it's lack of IV fluid or decreased amount of feeds, increased losses, okay? Whether it's GI losses or renal losses. And it's such an easy thing to treat. Just if they have an NG tube, just give them free water through the NG tube. You can use, the smartphone and you can calculate how much they need. The goal is to replace about 12 milliequivalents per day. But it's much easier to decrease the hypernatremia than correct the hyponatremia. So it's easier to do that. So be aggressive to treat this because this can make the patient super uncomfortable. If the patient doesn't have an NG tube, you can use D5W, just free water. Okay. I think that's it for my presentation.
Thank you, Dr. Aditya. Electrolytes are always a very complicated topic, but because Dr. Aditya made it simpler with the help of his cases, I think it has become clear to a lot of us. So thank you so much. And of course, those who got chocolates must be thanking you some extra. So we move on to the next speaker. Dr. Parmeshwari, please come to the stage to introduce her.
Now I introduce our next speaker, Dr. Anuradha Kamath ma'am. MBBS is from KEM Hospital. DA is from Sain Hospital, Mumbai. DNB is from Hinduja Hospital, Mumbai. Postdoctoral fellowship from Cardiac Anesthesia, Manipal Hospital, Bangalore. FTE fellowship in transesophageal echocardiography, senior consultant in our hospital.
Om Shri Sairam. Right now, I'm the fifth speaker for the day, and there is something to awaken all the people. Already, chocolates are there in the tummies, I suppose. So let's get up. What I'm going to do in this 15 minutes is just give you a brief outline. Then you can sit and read the presentation at leisure. This Parle-G, this biscuit is something which we all have eaten, either as a child or in a residency whenever we had those hunger pangs and we didn't have time to go to the canteen. And what does this G stands for? G stands for glucose. And my topic for today is glucose management primarily for patients in the ICU. Why is glucose so important? This simple looking molecule is actually the major fuel for all the cells in the body, especially for the cells like the brain and the RBCs, which do not have mitochondria and they cannot produce any ATP by themselves. So once glucose comes inside our body, it undergoes processes. If you remember our biochemistry, glycolysis, that is breaking down of the glucose to produce energy. In the presence of oxygen, it gives 280, without oxygen 2 ATPs, with oxygen 36. And the total opposite process of this is gluconeogenesis, wherein the glucose can actually be regenerated in our body from various other substrates like amino acids and so on in places like the liver, kidney, intestine, the liver being the primary source. So, we all watched this movie, we loved it. Just like maintaining the balance is important, in our body, we have two important hormones. One, insulin, and second is glucagon, which actually help us to maintain the normal blood glucose levels. So, what happens? How do they actually play? Once you eat food, your glucose levels in the body goes up. This stimulates the pancreas. The pancreas secretes insulin. Automatically the insulin will start breaking down the glucose in the liver and the glucose level comes down. On the other way around, if you are hungry right now, what has come into play is glucagon. The glucagon will cause glycogenolysis, that is the breakdown of glycogen in the liver. The glycogen gets converted into glucose and this glucose will provide you all the energy even when you are sitting and not doing anything. So, how does this insulin actually work? Insulin is a key. Even if you have glucose in the blood, without the insulin key sitting on the insulin receptor, glucose cannot enter inside the cell. This is very important because all the management that we do for our patients depends upon this concept. For the glucose to enter into the cell, you have various types of receptors. Some of them are dependent on sodium and some are not dependent. What does this insulin do once it enters into the cell? It helps in the uptake of glucose. It prevents the breakdown of proteins so that the proteins are used to maintain the muscle mass and not for generating more glucose in the body. It prevents unwanted breakdown of fat and helps in DNA synthesis. Now we all know, very simple. What is diabetes mellitus? They are of three types, type 1, type 2 and type 3. One which requires insulin and one which can be maintained with other drugs. So this is the big major chart, which is the type of insulin. You have the ultra rapid acting, you have rapid acting, short acting, regular insulin. That is the one which most commonly we use in the ICU, the human actropid, which when given subcutaneously acts in 30 minutes and the duration proceeds to 5 to 8 hours. We also have longer acting insulins like the glargine insulin and mixed combinations like human insulin and insulin aspart. Now, coming back, is just insulin and glucagon the ones in the picture? No. There are other actors in the play which are equally important. You have something which is called as incretins. These are hormones which are secreted by the intestine. They are of two types, GLP-1, which is glucagon like peptide 1, and GIP, which is glucose dependent insulotropic peptide. And on the other side, you have the counter regulatory hormones, which are friends of glucagon. They are cortisol, adrenaline, and the growth hormone. So, why do we need to know all this? This is because the incretins are the one which stimulate the glucose secretion, which reduce the glucagon secretion. And actually, when you eat food, that is the one which tells, yes, I am happy, food has gone in my tummy. That is a hormone which makes you feel happy and tells that you don't need to eat more food. Why you need? because these drugs are utilized for managing the sugar levels in the body. So if you can see the chart on the right side, you have multiple drugs. Ones which increase the insulin secretions like the sulfonylurea drugs, which decrease the glucagon secretions like incretin and amylin, which give you a feeling of happiness and appetite like the amylin, or neurotransmitters like dopamine. And you have other drugs which are also important for preventing the breakdown of fat. Two important drugs which are now coming in play are the SGLT inhibitors like the dapagliflozin and the DPB4 inhibitors, which are also used in cardiac patients, which help in preventing the breakdown of incretin. Why we need to know about this? We will see. Now, why are these important? Even when the patient is coming for surgery, most of the patients here are surgical patients. We need to remember that these oral hypoglycemic agents like metformin can cause metabolic acidosis. Second, sulfonylurea drugs, if continued, can cause hypoglycemia. The new group of drugs can cause ketoacidosis. The GLP drugs can cause delayed gastric emptying. Hence, you have to stop all oral hypoglycemic agents. If the patient comes for emergency surgery, you need to document that this patient was on these drugs and stop it immediately. Finally, with all these drugs, insulin, oral hypoglycemic agents, still the homeostasis is maintained, patient is happy, and you are in a steady state. Now, now I come to my topic, which is the ICU. ICU is when the patient is in critical illness. There is a total imbalance and the body tries to get back the patient to normal. We do multiple interventions trying to help the body to get this balance. Yet, first dictum, do no harm. Do we really always help the patients? Let's see. What happens when the patient comes to the ICU? In the ICU, the patient is in a situation wherein your insulin levels may be high, but he has got insulin resistance. On the other hand, the counter regulatory hormones, they are in all-time high. So what happens? You have breakdown of glycogen, glucose levels going high, you have breakdown of fat and increased production of glycerol, which again goes to this gluconeogenesis and more glucose production. You have breakdown of fatty acids, which causes ultimately ketosis. All this results in a state of hyperglycemia. At the same time, you are adding inotropes like adrenaline, which is actually a counter regulatory hormones. You are giving nutrition, IV fluids, dextrose containing. All of this cause hyperglycemia. Why is this hyperglycemia dangerous? Because glucose is a osmotic molecule. This will draw the fluid outside the cell. You have glycosuria and ultimately you have intracellular dehydration. Second, hyperglycemia can cause endothelial dysfunction. So there is decreased perfusion of the cells. That itself can cause acidosis. Third, hyperglycemia can cause imbalance in the natural immunity and the protective mechanisms which are there in the body. So the neutrophils, all of them cannot function properly. Hence, the end result is you have sepsis, you have multi-organ failure, and you have death. Hence, one, hyperglycemia is dangerous to the patient. So what did they see? They saw in each and every ICU, whether it was a cardiology ICU, wherein if you have patients coming in the CCU, you check the blood glucose levels 300. Why is it dangerous? Because it can actually increase the morbidity in a patient who is coming with MI. CABG patients, high blood glucose level, increased chances of graft dysfunction. In neuro ICU, you have a stroke patient, hyperglycemia increases in the chance of the infarct size. Poor longer stay in the ICU. In medical and surgical ICUs, there too you have increased chances of pneumonia, increased chance of renal dysfunction. Yes, so hyperglycemia needs to be looked over. But how much hyperglycemia? Initially, they just treated sugars of 220 because the old concept was 220 causes the renal threshold and you have glucosuria. So about 220, the sugar needs to be controlled. But was this sufficient? No. You had multiple studies. The first study they saw in 2001 to 2006, where they found that if you keep patient sugar between 80 to 110, 10 minutes over. Okay, you will have better sugar control. But the latest studies of NICE and sugar found that if you have strict sugar control, you have more incidence of hypoglycemia, and this actually increases the morbidity and mortality of patients. So, why is hypoglycemia dangerous? Because hypoglycemia kills the brain cells, especially in patients who are having ARDS, who already may be having hypoxia. Hypoxia and hypoglycemia is a dangerous combination. So, less than 70 is considered as hypoglycemia in case of adults. How do you do it? Yes, a awake patient will have sympathetic, he will be sweating, he will feel giddiness. And when you feel that, you follow the 15-15 rule. Give 15 grams of glucose for the patient and check again after 15 minutes if he's able to take orally. But in our ICU, the patients will not report because they are under sedation. You have intubated or ventilated the patient, and hypoglycemia can be missed. Hence, who are these high risk patients? Known diabetes, septic patients, women patients, patients who have got nutritional intolerance. These are the high risk patients. So, if you have hypoglycemia, you can treat it with 50% dextrose, 20 to 25 ml bolus, and keep checking the sugar after 15 minutes. Is only hyperglycemia and hypoglycemia sufficient? No. What they say is the pre-admission diabetes control, because the patient is a new diabetes patient in the sense he's a stress-induced diabetes or an existing diabetic patients. How do you check that? You check by doing a HbA1c. The reason is a patient who is already diabetic will tolerate high blood sugar levels better than a patient who is not a diabetic and has developed diabetes now because of our stress hormones. Hence, if you get a patient coming with high sugars to the ICU, please send a HbA1c. Other reason is overcorrection of hypoglycemia. Simple to give 50% dextrose bolus, but what they found is fluctuations in the glucose level that has got more morbidity and mortality rather than just having high glucose levels. The other point is time in target. It is better to have a longer duration of the patient with normal glucose level because that improves the patient output in the ICU. So, what are the targets? We have multiple associations giving us multiple targets. Ultimately, what are we to follow in our scenario? Simple. Keep the sugar between 140 to 180 for all the patients. Avoid strict control of blood sugars. But sugars of 110 to 140 are helpful in patients who are undergoing coronary artery bypass graft. If patient sugar is more than 150, patient is on inotropes or IABP, you must start insulin. If patient is coming for surgery, the duration of surgery is more than 4 hours, you have to intraoperatively give insulin infusion and control the patient's sugars. So, how do we decide? You can choose any algorithm, but that should be fixed for your ICU, and everyone should be on the same page when you monitor the patient. Few important points. What is the source of blood that you have taken? What is the site? What is the way you are checking the sugar? Is the patient anemic? If the patient is in shock or vasoconstricted and you use a peripheral pinprick method, your sugar levels will always be low. Has there been a delay in sampling? Because the RBCs will utilize whatever sugar is there in the blood and you will not get a correct sugar level. Now, there are various protocols. Just one of this is what I have mentioned, which you can sit in detail. Simply, whenever you prepare an insulin, remember, make it 1 unit per ml. Insulin sticks to plastic. So always remember to flush the pressure line or the infusion line with 20 to 30 ml because it's only then that the insulin will actually reach the patient. Third is that you have to preferably give IV insulin because in shock state, subcutaneous insulin in peripheries are cold will not get absorbed. So you will write 6 units insulin given subcutaneously, but the insulin has not reached the patient and he needs to get IV insulin. Other thing is how frequently you check. Check the sugar ideally every hour. Once the blood sugar levels are holding on in normal levels, then you can make it less frequently, once in 2 hours or once in 4 hours. If the sugar levels are less than 40 or showing high on your glucometer, you need to reconfirm by sending lab values. I'll take 3 minutes more. How do you check what glucose level you have, how much insulin to give? One simple formula is whatever is the blood glucose, say it is 220, 220 minus 60, whatever you get, that you multiply by 0.02, that much insulin infusion you should start for the patient. Now, what you have to remember by giving insulin, insulin pushes the potassium inside the cell. So please monitor the potassium when the patient is on insulin infusion. Now there are multiple regimes which I said. This is a regime which is being practiced in CMC Vellore, where they say for every 50 units, 50 grams of glucose, you have to give 1 unit of insulin. Coming back to all the major insulin, remember, once the patient has been on stable infusion of insulin, his blood sugars are maintained, you have to convert it into subcutaneous insulin. So how do you do that? You see the insulin infusion which was for the last 2 hours, multiply by 12, say the patient gets 30 units of that, and then you divide it. 15 units is goes for the basal, and the 15 units which are left, you will divide it into the 3 meals that the patient takes. So if the patient is not taking an adequate meal, you can cut down the insulin requirement. Finally, a last thing about a dreaded thing is DKA, diabetic ketoacidosis, wherein all these problems of hyperglycemia ends up with acidosis for the patients. So what you need to remember in this is, these patients will have high anion gap, which means because the ketoacidosis are produced in the body, the bicarb gets utilized for utilizing this acid, and you will have, if you do an addition of sodium plus potassium and subtract bicarb and chloride, you will have a high difference between them. So how do you see these patients? He will have polyuria, polydipsia, headache, acidotic breathing. Once you see this patient, confirm. If acidosis is severe, if the patient is in shock, you have to go for ABC. If the acidosis is moderate, you start with hydrating the patient. If the acidosis and dehydration is mild, you can give subcutaneous insulin. First thing in DKA is give fluids. Reason is, when you give fluids, it's only then that the dehydration will settle and insulin will actually be able to reach the cell. Also, do not give potassium and do not give insulin till your potassium is normal. If potassium is less than 3.3, do not give insulin. First correct the potassium and then go for the insulin. So these are multiple charts which you can sit and read at leisure. One more entity which is there is called as hyperglycemic hyperosmolar state, in which the sugar levels are high, but the insulin secretion is still there. So there is no breakdown of fat, but all the things of high sugar levels are still present in the patient. Finally, a last thing on neonatal or pediatric hypoglycemia. For them, sugar levels less than 40 is considered to be in pediatric as hypoglycemia. For neonates, it's up to 20 to 25. So, how do you correct this hypoglycemia? This, what I've given is AIMS protocol. They say give 2 ml per kilo of 10% dextrose and keep checking the sugar every 15 minutes. Give formula feeds or mother's feed simultaneously to try and get the sugar levels back to normal. There are multiple further studies which need to be done, and the take home message is maintain sugar between 140 to 180, send a HbA1c for all the patient, and stick to the protocols which are followed in the hospital. Thank you.
This is USB, this one. This one. You see this side. Ah, no.
Thank you, ma'am, for the beautiful lecture. Now I introduced our next sir, Dr. Aladi Mohan sir, MD Medicine, AIMS New Delhi, FRCP Aiden, FCCP USA, FAMS and FICP and FIACM. Professor, Head of Department of Medicine, Chief, Division of Pulmonary, Critical Care and Sleep Medicine, Sri Venkateshwara Institute of Medical Sciences, Tirupati. Aladi Mohan sir stood first in nationwide entrance test and did his MD medicine from AIMS, New Delhi. During his undergraduate and postgraduate period, he was first among the first ranking students, best outgoing student, and was the recipient of 28 gold medals and prize, including the Sri Mohan Lal Vig Gold Medal.
Incidentally, it is in every presentation. Okay. Namaste, everyone. I come from the holy city of Tirupati, from the Sri Venkateshwara Institute of Medical Sciences. When Professor Guntupalli Madam asked me to speak on this topic, the challenges faced in a tertiary care medical intensive care unit. In the next 20 minutes or so, I'll share our victories, our lapses, and our gains and pains in managing patients in an ICU. I take care of the medical intensive care unit, which is different from the ACC, anesthesia critical care intensive care unit. So we are physicians taking care of critically ill medical patients. So the flavor will be different, the choice will be different, and the disease spectrum will be different. I have not received any funding for presenting this talk, and I have no conflict of interest. So in the next 20 minutes or so, I will try to share with you something I have learned with this, starting with this case vignette. Here we have a young male. He has a 4-day history of high-grade fever, jaundice, oliguria, gum bleed, respiratory distress. Physical examination shows icterus, petechiae, cyanosis, a rapid thready pulse. He is in respiratory distress and is in shock. The arterial oxygen saturation measured by the pulse oximeter is pretty scary, and there are bilateral frontal opacities on the chest radiograph. This is a patient nobody wants to treat in Tirupati. No corporate hospital, no private hospital, no commercial hospital wants to treat. So this is what we live with day in and day out. So what was the working diagnosis? We have the issue of an acute febrile illness, acute undifferentiated febrile illness in a young person with no comorbidities, with multiple organ involvement syndrome, acute respiratory distress syndrome. Then what are we dealing with? So given this bread and butter kind of cases which we see, what do we see and how to approach these cases? The spectrum of diseases in the MICU, as we see in India, are somewhat different from the classical spectrum which is seen in the Western ICUs. We do see multiple blood transfusions, but heat stroke is very significant problem, especially in the hot summers. The what is not clearly readable on this slide, I don't know why the colors changed. We have a spectrum of illnesses ranging from TB, malaria, scrub typhus, leptospira, scorpion sting, and so on, and poisoning, and so on and so forth. And the new kid on the block, which we have learned from in the last 3 years, has been COVID-19. So I'll attempt to show the forest, a glimpse of something of everything. So what do we have as evidence from India and from our own experience? What are the challenges with COVID? I think everyone is tired of COVID. Everyone wants to have amnesia about COVID. But it's sometimes good to have bad memories. The good, the bad, and the ugly of COVID is indeed something which is an ongoing lesson. The typical presentation of COVID is known to everyone, so let's not beat it further. But what we have seen is presentation with other acute medical illnesses and the patients were detected to have COVID-19. Is it coincidence? Is it coexistence? Or is it a myth? We don't know. But for once, if you look at the way internal medicine, general medicine, or medicine, plain medicine is practiced all over the glorious city of Bengaluru, most often the MIs, the strokes, the Guillain-Barrés, they go to the subspecialist. The internal medicine chief is the head postmaster of Bengaluru, refer to cardiology, refer to neurology. So हमारे पास तो इज्जत है, हम तो physician हैं. So luckily, because of COVID, the subspecialists had run away, dumping everything on our head. We thought it's a 3-year learning course. And when we looked at the other things is coexistent COVID-19. Many of you won't believe. Everyone who is coughing was not COVID. It was active TB as well. It was ARDS due to TB as well. I will show you what we saw. And when patients were electively admitted for other medical surgical illnesses, the surgeons, before they sharpened their knives, rule out COVID. Rule out COVID. That was the thing. And we were a state COVID hospital catering to 5 districts, and for 2 years did nothing but COVID and COVID and COVID. So let's see some of these. Some of the cardiac manifestations must be familiar to people in the Sri Sathya Sai Institute of Higher Medical Sciences as well. Many unstable anginas, otherwise stable patients, no reason sitting at home, scared of death. They have developed no exertion, no emotion, no exercise, importantly. They have developed unstable angina, whether it is, and they tested positive for COVID concurrently. So we made it a point to test everyone who presents with an acute coronary syndrome, either an unstable angina or an acute MI, with COVID-19 testing, because whether the COVID-19 caused a hypercoagulable state or whether the vaccination itself predisposed to it, I don't know. Wanted to look into this, but with 250 admissions per day, it was impossible to even eat food. So peripheral arterial disease is also uncommon. We saw a patient who presented with this thrombosis, and initially patient had no fever, no cough, no sore throat, tested COVID positive. A patient underwent surgical procedure and thereafter had to be treated for COVID. Luckily, our cardiothoracic surgeon was keen enough to interact with us. The patient survived. There are some very interesting neurological manifestations in patients with COVID-19. This is out of the 16,802 moderate, severe, or critical ill patients. None of these are mild patients. Mild patients we were not eligible to admit. We were a state COVID hospital. What we have seen is interesting. We had ischemic stroke, hemorrhagic stroke. Guillain-Barré was very atypical, but patients had to be treated for COVID-19 as well. They had other biomarkers of COVID-19 activity, such as CRP, which were raised significantly, and they also had chest lesions on imaging. This was not simple Guillain-Barré per se, which was occurring. We had many other neurological manifestations ranging from normal pressure hydrocephalus, acute demyelinating encephalomyelitis, peripheral neuropathy, CIDP, and so on. Even myasthenia gravis, one patient had presented to us. So these were all isolated individual cases, but they were a good learning point for us to reassess ourselves. One issue we had to contend with was we were short of ventilators. In the 5 districts, we had 110 ventilators for COVID, but they were not sufficient. So because everyone who needs oxygen was shifted to our center. So we did a RCT of HFNO versus non-rebreathing oxygen face mask. And our observations have shown that the use of the non-rebreathing face mask was at least as good or better. We think this is a little underused or undertested. Everyone was going after NIV. You can't really do NIV for a COVID patient. They are an altered sensorium. They are agitated. They'll never keep the mask. And intubating them requires a humongous amount of manpower. I'm not sure every day who would come to duty, because half the team would test positive and would have to be admitted. So we wanted some evidence. So this RCT, we have shown that the NRBM used properly is at least as good as HFNO. It is much cheaper to use also. And another thing which bothered us was the sample. Patient comes to the triage, from triage goes to ICU. The sample has to be collected, RT-PCR, it has to go to the lab. So what is the transit time? From Ayodhya to Sri Lanka, how Rama traveled. The issue was, what happens to the sample? Is the cold chain maintained? So we were really worried. Are we missing positives because of our inability to transport from the COVID block to the virology laboratory? So we did a study. Our observations have suggested that there was no significant difference between the RT-PCR results of samples stored at 4 degrees and room temperature up to 5 days of collection. Because my lab was bombarded with 10,000 samples per day in multiple cardboard boxes, impossible to process under 24 hours. Rat came later, but rat had its own variations, so we had to go by RT-PCR. So not a great rocket science, but are we messing or missing something was the issue to contend with. TB-ARDS is a very interesting entity. People think of TB as a 3R Bahubali 3, but TB is not necessarily a 3R Bahubali 3. It can be a 30-second ad spot also. So the ARDS has been described in PTB and MTB. There are not many large cases. I feel these series we did with Professor Guntupalli Madam is still the largest in the world today. And we have published on this issue from several aspects. So if you look at the what is the burden of TB-ARDS globally and in other tropical countries, the data are not comparable because the denominator is different. But one subtle point I wish to highlight here is miliary TB is more likely to develop ARDS than pulmonary TB, and the diagnosis does not again require rocket science or Newton's laws of motion. Simple tracheal aspirate. We used to do the Zeal-Nielsen stain for AFB earlier. Now we do the expert MTB RIF or the gene expert. With this simple measure, we could get the diagnosis under 24 hours, and we were able to initiate anti-TB treatment. Anti-TB treatment, what is the challenge in the ICU? In India, there are no injectable preparations. Either you have to put in a Ryle's tube, break the rifampicin capsule. I have done rifampicin pharmacokinetics. It's not that easy. It doesn't dissolve well at all. And half of it will stick to the Ryle's tube. So these are all practical issues. I think our nurses, like many of the nurses here, they are godmothers to us. And they used to hit our postgraduates hard and tell them that's not the way you do. So I'm indebted to the teacher in them. And we are very fortunate that way. So this is the paper which came in the International Journal of TB and Lung Diseases. And a word about ARDS in malaria. We are a malaria endemic zone. The Tirumala Hills is a part of the hyperendemic area for malaria. And we get at least 8 to 10 falciparum malaria per day. We get only severe complicated falciparum malaria, else get treated. Outside, it has been described in up to 10% of patients with severe falciparum malaria. ARDS in falciparum malaria is very tricky. Why I show you? It is rare with Vivax, but more common with falciparum. I don't want to provide a set of binoculars to read this slide, but please see this part. With anti-malaria treatment, the patient recovers, the fever goes down, the parasite load is coming down, patient looks better. But due to a persistent immune response, patient develops ARDS. So please understand, when you are dealing with ARDS, when you deal with a severe complicated falciparum malaria in your ICU, patient is, you have made a diagnosis day one, whatever diagnostic test you have used, patient has improved, and the patient is coming off all the tubes, but then suddenly the patient crashes. It is malarial ARDS. It is malarial ARDS. We have got proof from postmortem lung biopsy. Bug is sitting there. Bug is sitting quiet, and we have seen this to be related to the persistent immune response. So please remember one learning clinical point. ARDS, with the patients with severe complicated falciparum malaria, day 4, day 5, as they improve also, fever comes down, still they can develop ARDS. So these are the various series, including what we have published some time ago. 5% of patients, even with uncomplicated falciparum malaria, who are the OPD patients, walking, talking ones, they suddenly deteriorate. This has been a very important learning experience. Extremes of age, pregnancy, and immunocompromised state are associated with a poor outcome. Leptospirosis is an interesting disease. Many of us, when it rains buckets in Bengaluru, are worried about our moccasinos, our Nikes, our Adidas. We remove the shoes, tie the shoelaces, hang that around our neck, hold the trousers, remove the stockings, walk barefoot in the roads. Drainage water contaminates with rainwater. Best opportunity to get leptospira. Save the shoe, save your shoes, visit the ICU. That's what happens. And thought to be the disease of laborers, sewage workers, paddy field workers in the past, it is the disease of urban dwellers. The unfortunate part is it is missed because it is not thought of. Then enteric fever is another important cause of ARDS, not very common, but treatable cause of ARDS. In ARDS, the issue is how early you make the diagnosis and institute the specific treatment. Respiratory treatment, the respiratory support is another story altogether. It is an early manifestation. Normally, at 1 week fever, early enteric is not really thought of. These days, we are getting patients in the MICU. Febrile delirium patient, enteric fever is an important cause. One learning tip, the good friendly old peripheral blood culture is not growing the bug. We do clot culture and bone marrow aspirate culture. The yield is very good. All these ELISAs, they are good, but they are secondary evidence. But these two are very useful. 80 to 90% yield, I have experience of 30 years. Scrub is another new kid of the block. And we had not much idea about, we did not have much idea about scrub typhus till about 2009-10. We started having a spate of patients with multiple organ dysfunction syndrome and ARDS coming. They were admitted to the MICU because like we have something called diagnosis of exclusion. Nobody knows what is happening. You give to medicine, they will break their heads. So this is the kind of patients I deal with. Fortunately or unfortunately, when I was a medical student, I had opportunity to see the lesions of scrub. So this patient was admitted in the MICU, and all causes under the sun were being considered. And when I had taken the round, what my boss, Professor Sharma, taught me, strip the patient, examine fully. In the era of non-contact telemedicine of COVID, that doesn't seem to happen. We unfortunately still touch patients. Hastavasi. So to enable allopathy to have the grace of Venkatachalapathy, we need that conductance through the physician's hand. So when we looked at the patient, we saw this cigarette burn-like lesion. And if you see this another patient, this is another patient who had a differently aged lesion. I told stop all IV antibiotics. They said you've gone mad. I said I'm not mad. Give doxycycline, 100 milligram BID. Next day patient sat up. Trust me, it is such a miracle. It works well. Eshkar, if you are lucky, you will have the divine munificence to have that lesion to guide you. Else, laboratory, your immunological diagnostics are widely available. They are fairly rugged with reasonable sensitivity and a very good specificity. So the various complications are listed in this laundry list. My time is Indian standard time, not Indian stretchable time. So I appeal to you to have a quick glance at it. It presents with every damn thing under the sun, from head to Naka Sika Paryantam. Naka is nail, Shika is my tuft of hair. It is there from head to toe all over the body. Scrub typhus is eminently treatable. Recently, we completed one clinical trial called INTREST trial, INTREST. It is funded by Wellcome Trust. That paper is due to appear, I think, in one of the March issues of the New England Journal of Medicine. It's done in 11 centers in the country. And for a black skinned person to get into any gym is not easy. It was a good clinical study. We tried a combination of only doxy IV, only azithromycin IV versus combination of doxy plus azithromycin. So I think which is good. I don't want to release the suspense of Bahubali 4. So please read the paper. So toxin fume inhalation. Very often chlorine gas exposure is very common. Tanker crash on the road, swimming pool which is being cleaned up is messed up, and so on. So this is also a very common cause of ARDS and acute respiratory failure requiring assisted ventilation. So in our patient, we did all these diagnostic tests. This is the sensitivity and specificity of various tests for the acute febrile undifferentiated illness, all tests including H1N1 and COVID-19. The management initially included fluids, vasopressors, specific treatment for whatever these were. Okay, I'll finish in 3 minutes. Right. Then we started the patient, awaiting the lab results. If you wait for a result to treat, the patient will not be there to treat. So we set aside science and practice the art of medicine. This is a real life scenario. We started on IV safe trioxane, artesunate, and oral doxycycline for severe complicated falciparum malaria. The clinical pearl is in the tropics due to obscure etiology. It is common practice to empirically start a combination of IV antibiotics, which covers Leptospira scrub, S. typhi, and other gram-negative organisms, antimalarials, plus anti-TB treatment when relevant, very early, even though it is an acute presentation. Of course, all this has been covered in greater detail by my other esteemed colleagues. But a word about NIV. It seems very attractive. NIV should never be taken up in a center where they cannot do tracheal intubation and provide assisted ventilation. Two, in tropical illnesses in the ICU, NIV, though useful, it is difficult. Patients are in altered sensorium or in coma. It is not possible to apply NIV. So during COVID, we had umpteen hazard offers. We will give NIV, we will give NIV. Initially, we were jumping up and down with joy and ecstasy. Then we realized that it doesn't suit the kind of patients we were seeing. So we went into oblivion. So the standard protocol for the ARDS net protocol ventilation works in most of the tropical diseases. Also, I quote my boss, whatever treatment, whatever mode of ventilation you are providing, do it early. If you do it late, it's what's gonna be. Okay? Sera. So do it early. Do it aggressively is the take home message. There have been some predictors of outcome, and the clinical presentation of diseases can be atypical in the tropics. A high index of suspicion is important. Etiological diagnosis should be established fast by thorough clinical examination, which should never be missed, and appropriate laboratory testing, including early, aggressive, invasive diagnostic sampling. And specific treatment, if instituted early, can be life-saving. I conclude my probably 3.5 minute delayed presentation by quoting from the Kenopanishad. I think this spiritual center will appreciate what the seers, the rishis of the bygone era have said. Naham manye suvedeti nona vedeti vedacha yo nastad veda tad veda nona vedeti vedacha. I think not that I know it well, and yet I know that it is not unknown to me. He of us who knows it knows that. He knows that it is not unknown to him. I think the spirit of science is enshrined in our tradition, and it is up to us to realize, to recapitulate, to regurgitate, to reinforce, and implement in practice rational scientific management of critical illnesses. I thank Madam Guntupalli Garu for providing me this double dhamaka, as they call. There is a double ka meeta suite in Hyderabad, 2 talks on one day, and I'm able to make it today by God's grace. Thank you, Pankaj sir, for your guidance, and thank you one and all.
Thank you very much, sir. That talk was definitely so enlightening. Thank you for sharing all your experience. Since many of us don't see medical patients here, we see mostly surgical patients. So this has been a very, very valuable learning from your talk. Now we will all break for tea, and tea has been provided here itself in this very hall. So please kindly take it, and after that we'll have one more session here. Lectures are going to continue. Workshop for doctors is going to start in the skills lab, the POCUS workshop. So whoever wishes to proceed to the skills lab can please go ahead and join the workshop. Uh, Lectures are also available on YouTube. So people who are going to attend the workshop will not miss that. They can attend, they can log into YouTube, and they can hear those lectures. So let us all break for tea right now. Thank you.
This password will put.
I'll call. I will call. Keep it here, okay? You should take this and stand there. I I will tell them name. Felicitate, no?
I'll give him the certificate.
She will give it. Oh, she will start it. Yeah.
You give him the flower, I'll give him the certificate. We'll start it, Dr. Kalpala.
Hello. Hello. Good afternoon, everyone. Had a nice cup of tea and biscuits? And all ready for the next section now? Yeah. Okay. We'll start the next two sessions are remaining. We'll start this session. Before starting the session, I request our director, Dr. Sundaresh, to felicitate all the speakers who are present here. I will request sir to felicitate Kalpalata madam first. Shri Devi madam. Dr. Aladi Mohan sir.
You go in front and give to sir. To Chellam, sir. Yeah?
Our own Dr. Chellam sir. Sir, come. Yes. Speaker sir.
Sir went there, no? Aditya sir went there.
Dr. Aditya sir. Dr. Dharni ma'am. Some talks are not done yet, but we are felicitating you. Dr. Shivani Agrawal. Our own Dr. Anu. Thank you. Thank you so much, sir.
This. No, sir is a.
So we are giving to the speakers, but you just felicitate Dr. Vrushali. So would you like to just speak two words only?
Thank you very much.
Four? There were four?
I think academic sessions should not have long, unimportant talks. So that's why I chose not to speak. Thank you very much, everybody, for coming here.
Thank you, sir. Thank you so much. Let us start the third session. So now the third session is supposed to be on cardiac. But as you know, so many cardiac surgeries are happening, and we see these patients out of the cardiac ICU also. So the first talk is on Fontaine. You will feel what this talk is, the girls who are not in ICU, cardiac ICU. But let us learn about those things also. Dr. Sweetie will introduce the speaker.
Now I welcome Dr. Shivani Agarwal Madam for giving the next talk. Madam has done a residency from Medical University of South Carolina and graduate of Adi Chunchanagiri Institute of Medical Sciences. Warm welcome to Dr. Shivani Agarwal Madam for the next talk. Ma'am will talk about post-operative fluid management in cardiac surgery, mainly Fontan surgery. Thank How to this mic on?
Sairam, everyone. First of all, I'd like to sincerely thank all the organizers for giving me this divine opportunity to speak at such a wonderful institution, what I consider my home. So today, the objectives of this talk, it's a quick talk. We're going to quickly cover post-operative cardiac hemodynamics and factors influencing the hemodynamics. We're going to cover the principles of post-operative fluid and other management because it's hard to separate out fluid management from other post-operative management. And then in order to talk about Fontan management, we first need to understand Fontan anatomy and physiology, understand post-op Fontan hemodynamics, and then we'll talk about assessment of Fontan's fluid status and post-op management in Fontan patients. So let's talk about hemodynamics after cardiopulmonary bypass. So all of you who've worked in a cardiac intensive care and have received patients after they've undergone cardiac surgery, been on cardiopulmonary bypass, you will know that the first 6 to 12 hours is usually the time when these patients are the most hemodynamically unstable. And this is usually followed by sort of a period of recovery, but the duration and intensity of this instability is dependent on mainly two types of factors. The first factor is the severity of the underlying cardiac disease. So if someone goes in with bad LV, bad RV function, when they come out, they're going to be more unstable than a patient who goes in with good function. If they have a lot of valvular regurgitation, that's going to affect their hemodynamics when they come out of the operating room. And then the other major group of factors is the actual intraoperative event. So it's important to know what has happened in the OR to know how that's going to affect the hemodynamics. Was there a lot of bleeding? Did the patient require a lot of transfusions and blood products during the surgery? How long was the patient ischemic for? So how long was the heart not beating while the surgery was done on the heart? And then what sort of myocardial prevention was used? So all of these are extremely important to assess what the postoperative hemodynamics are going to be like. And what happens exactly in cardiopulmonary bypass? So basically, cardiopulmonary bypass is just what it says, right? We're bypassing the heart and lungs. So the patient is taken into the operating room, and then we are taking the venous blood, and instead of it going through the heart and lungs and then going to the body, the venous blood is taken out from the SVC and the IVC. Usually that's where they cannulate, and then put into the cardiopulmonary bypass machine. And then that bypass machine delivers oxygenated blood to the aorta so that it can perfuse all of your vital organs. Now, in order for this cardiopulmonary bypass to work, you have to prime the circuit. You have to use a lot of fluids. You have to oftentimes use a lot of blood products. And so all of this, despite aggressive efforts not to give them a lot of volume, when patients come out of the OT after they've had their surgery, they usually have a significant amount of sodium and water overload. So they come out a lot wetter than when they went in. And then when you imagine all of their blood is taken out, and then it's exposed to all these foreign surfaces in the bypass machine, that's going to cause a huge inflammatory response, right? There'll be activation of all these cytokines, there'll be a lot of inflammation. So that causes this diffuse systemic inflammatory response. There'll be a lot of coagulopathy. The multiple organs can get affected, so there can be multiple organ dysfunction. And then what about the myocardium itself? When you operate on the heart doing a bypass, you basically are stopping the heart, right? You're stopping the heart. So the myocardium itself is not receiving oxygen supply. And we try to protect it it by paralyzing the heart muscle. We try and protect it by cooling the patient, but still the myocardium can get some degree of injury, ischemia, and then when you you put a cross clamp across the aorta before you start the surgery. When you remove that aortic clamp and you perfuse the heart again, you can cause reperfusion injury. So this can lead to a lot of myocardial dysfunction, which also will affect your postoperative hemodynamics. And then we resuscitate both during the surgery and postoperatively. And ultimately, when you're resuscitating, you're trying to get adequate oxygen delivery to all of your organs. And then you're also trying to achieve hemostasis because you're cutting a lot of blood vessels, you're cutting the heart, so it can be difficult to achieve hemostasis. These are the two endpoints of resuscitation post-cardiopulmonary bypass. So what about the initial hemodynamic management? Your patient has gone to the OT, they've come out, you've had a good handoff between the surgeon and the ICU so that you know what's happened intraoperatively, and that'll help you to know what the hemodynamics are going to be like. Your patient usually comes out very wet. They have a lot more fluid and sodium on board, but they're also very leaky. Their blood vessels are leaky. A lot of the fluid which they have, it's not in the blood vessels, it's in the tissues. So within the blood vessels, the intravascular volume, that's still often very low. And so, despite them coming out with a lot more fluid on board, initially, a lot of these patients do require a lot more fluid resuscitation. And then we talked about them having myocardial dysfunction, right? Because of the ischemia which the myocardium undergoes. So they may need inotropes to support the myocardial contractility. If their heart is not functioning well, we may need to lower the systemic vascular resistance so that the heart is not pumping against a very high pressure. And so for that, we may need to dilate the blood vessels. Then we also talked about they may have vasoplegia. Their vessels may come out very dilated depending on what their liver function is, their kidney function is, the cytokine release. So they may need vasopressors. So all of these vasoactive drugs are used then to stabilize the patient. And then once you've stabilized the patient, you have all this extra fluid and volume on board. That's when we need to start diuresing the patient to get all of that off post-cardiopulmonary bypass. So now to talk about post-operative course in a Fontan patient, first we need to understand Fontan anatomy. So Fontan patients are basically patients who are born with one single pumping ventricle. So they have one of the ventricles is well developed, and the other ventricle they're born with is not well formed. It's a hypoplastic ventricle. It could be the right ventricle, it could be the left ventricle, but it can't pump well. So essentially you have one good functional ventricle, and that ventricle is used to pump to the aorta, to the body. What about the pumping to the lungs, which the right ventricle normally does? That pumping does not occur. We bypass that part of the circuit. We take the blood from the SVC and the IVC, the venous return, and we connect those vessels directly to the pulmonary arteries. So all of that venous blood, instead of going to a right ventricle and getting pumped to the lungs, sort of passively flows to the pulmonary arteries, and then from there to the pulmonary veins into the heart, and the heart, which has a single ventricle, pumps to the body. So that's what a Fontan circuit looks like. You can imagine it's not very efficient. Blood always flows from higher pressure to lower pressure. So in order for the blood to flow from your Fontan through the lungs and then get to the heart where it can be pumped to the body, the Fontan has to be at a very high pressure. So your pressure, your venous pressure is very high, your systemic venous pressure. So the Fontan itself, we talked about it could be a hypoplastic left ventricle, a hypoplastic right ventricle. So there are many underlying diagnoses which end up with a Fontan circulation. We have tricuspid atresia here on the left. We have a hypoplastic left heart on the right. So the underlying anatomy will also affect your hemodynamics. So thinking of this, the Fontan physiology, basically, it's a single ventricle that pumps to the systemic circulation and then passive flow of blood to the lungs. And so as a result, what happens is you don't have this pulsatile flow going to the lungs. Instead, you have passive flow. So your peripheral pulmonary vasculature over time there'll be a little loss. And your pulmonary vascular resistance also over time increases. We talked about the Fontan circuit having very high pressures. So there's chronically elevated venous pressures, and that will lead to a lot of liver congestion, which can aggravate your vasoplegia, which we talked about happening post cardiopulmonary bypass. And for this to be functional, not only does there have to be a good preload in the Fontan circulation, so you need adequate pressure in the Fontan circulation for forward flow to occur, but it has to flow through the lung circulation. So the pulmonary vascular resistance also needs to be low for a Fontan circulation to function. So given this physiology that we understand, what are the post-op hemodynamic goals in a Fontan? One, we need to maintain preload because the Fontan circulation is dependent on this preload for forward flow. We need to decrease the pulmonary vascular resistance, and then we need to maintain myocardial contractility. These are our 3 post-op hemodynamic goals in a Fontan. So what about management and attainment of these hemodynamic goals? How do we assess whether a patient is hypovolemic, hypervolemic? Why are they hemodynamically unstable? So normally with ideal anatomy, you see that it's labeled as PA pressures. It's the same pressure in the Fontan circuit and the pulmonary arteries. That normally we try and maintain at about 10 to 15 millimeters of mercury. That's sort of the ideal Fontan pressure. And then the atrial pressure, here it's labeled as LAP, but it can be a right atrium or a left atrium or a common atrium. But the atrial pressures are usually fairly low, between 2 to 6. So you have that nice gradient from the Fontan to the atrium. And that gradient, you don't want that to be too high either. Is it 15 or 10? 10, okay. So you don't want that gradient to be too high. If that gradient, that's called the transpulmonary gradient, is high, that will be because of increased pulmonary vascular resistance. So you need to have a nice low transpulmonary gradient. So normally we have a high Fontan pressure, low atrial pressure, low transpulmonary gradient, and low blood pressure so that the heart doesn't have to pump against a lot of afterload. What happens when the patient is hypovolemic? So you can assess that a Fontan patient is hypovolemic. Their Fontan pressures will be low and their atrial pressures will be low. They'll still have that low transpulmonary gradient, but if you have those hemodynamics, that's suggestive of hypovolemia. And those patients will need fluid resuscitation in order to facilitate the Fontan circulation. Conversely, if you look at the line which is labeled elevated LA pressure, if you have high Fontan pressures and high atrial pressures, that will probably be due to ventricular dysfunction. Because if you have poorly functioning, poorly contracting heart, the pressures in your heart are going to be high, the pressures in your atrium are going to be high, and then your Fontan pressures need to be even higher so that there can be forward flow. So then you might need to use inotropes instead of using fluids in that situation to help the forward flow. So this is how you can sort of assess the hemodynamics in a Fontan patient and assess whether you need to give fluids or inotropes or how you need to resuscitate the patient. The other important things in postoperative Fontan management, if they are on a ventilator, you are giving positive airway pressure. If you're giving positive airway pressure, that is not going to facilitate the flow through the lungs to get to the heart. So we want to try and wean them off the ventilator either postoperatively in the OT or as early as possible after they come out. We monitor for decreased cardiac output, and the reason for decreased cardiac output, is it hypovolemia or is it decreased myocardial contractility? If the patient is still on the ventilator, the Fontan pressures need to be even higher. So if it's 10 to 15 on a non-ventilated patient, on a ventilated patient, you may need 15 to 20 millimeters of mercury. And then you want to avoid anything which is going to increase your pulmonary vascular resistance. So metabolic acidosis, hypercarbia, hypoxia, all of those need to be treated aggressively to maintain low pulmonary vascular resistance. So everything that you can do to lower the pulmonary vascular resistance after they're extubated, you want to do aggressive pulmonary toilet. Don't let them get atelectasis. Ambulate them early to open up their lungs. Monitor their chest tube output carefully. Monitor for arrhythmias, which can be difficult to diagnose in Fontans, and treat them aggressively. So this is our sort of, from Texas Children's Hospital, how postoperative Fontans are managed. This is in the pediatric setting. So if you have an adult Fontan patient, the management's a little bit different. But this is from a pediatric Fontan patient. You'll see initially they're given a lot of fluids to maintain the cardiac output, and then we start diuresing them after that. And then, of course, they may need inotropes depending on, what their cardiac output is. And then we try and get them off the ventilator as soon as possible. Initially, maintain them on a little oxygen to help lower the PVR, and then we can withdraw that. We try and get the chest tubes out as soon as possible, and very early ambulation, good pain management to prevent increased demand. So that's in a nutshell. To understand how to manage a patient post-operatively, you need to understand the hemodynamics. You need to understand that Fontan circulation is dependent on good preload and low pulmonary vascular resistance. And we need to understand the goals of fluid management in a Fontan post-operatively, and how we can assess their fluid status and hence learn to manage them. These are my references. Thank you, and Jai Sai Ram.
Thank you, thank you. Thank you, ma'am. It was a very wonderful presentation. I think all girls who are working in cardiac ICU as well as not working in cardiac ICU came to know what a Fontan surgery is and what we should do at all if you are posted. Correct? Now you have finished your night duty. You don't know what has happened in the ICU or in the OT. And now you have come as a new person, as a new duty a person in the morning. And patients are on ventilator or patients are extubated, and suddenly the lab values come and you are very tensed. Should I report this value? The value looks okay. What should I do with this? So which are the values to be noted, to be treated? Next lecture is going to tell us more about it. Dr. Sweetie will introduce the speaker.
Now I welcome Dr. Sridevi Deviraj Madam for the next talk. Ma'am is the professor and medical director at TCH Lab and at Baylor College of Medicine. Ma'am has done a clinical fellowship at University of Texas Southwestern Medical Center, United States, and done advanced training at the same institute. Ma'am has earned a PhD from Postgraduate Institute of Basic Medical Sciences, University of Madras, and done MS from the same institute, BS from Ethiraj College, University of Madras. So a warm welcome to Dr. Sridevi Devraj Madam to give a talk on critical or panic lab values reporting and acting on them. Thank you.
Thank you very much for that introduction. Humble pranams at the lotus feet of Bhagavan Sri Satya Sai Baba. Thank you everybody for staying for this session. Thanks Dr. Guntapalli and Dr. Dr. Puneta for having us here and your hospitality. And it's lovely to see all your faces. Now I'm going to have a different aspect of the whole session that we were having this morning. Every talk that you heard about, you talked about hyponatremia, hyperkalemia, hyperchloridemia, whatever that you talked about, cardiac markers. You always have to talk about a lab value, be it point of care, be it from the lab. So big shout out to the nursing team that acts on these values, and a huge shout out to the lab team that makes sure that all of these values that you get are actually appropriate. Okay, now that my job is done, I can go on to the next one. Okay, so here is a 62-year-old man who arrives at the ER with just a headache, a nausea, delirium. We saw one of those patients earlier this morning. He has low blood pressure. He says he feels like he's going to pass out. And after viewing the patient's record in the EHR, the nurse discovers that he's had an appendectomy about 3 weeks ago, and the ED provider decides to keep the patient overnight for hydration. He orders the usual labs. He orders a CBC, he orders basic chemistries, and hours go by, the patient starts feeling worse. He's breathing more rapidly. He has sharp growing pains in his right lower abdomen. So the attending is called. He's concerned, of course, for infection, and he orders an abdominal X-ray, more blood work, and like Dr. Mohan said, didn't wait for the labs to come back, but he's started him on broad spectrum antibiotics. Now, the nurse caring for this patient acknowledged the orders, and she waits for the radiology to do the x-ray, the phlebotomist to draw the labs before administering the antibiotics. Another hour goes by, unfortunately, without any labs coming back or any results coming back. Alarms start beeping, the patient's heart rate drops significantly. The nurse rushes to the room at that point. Patient's breathing and heart rate completely stop. She calls a code, but they're unable to resuscitate the patient. And this happens, unfortunately, more often than we want it to happen, correct? So, how do we avoid such situations? So, following the code, the provider sits down and he notes that in the medical record, there is a worsening WBC count, a really low platelet count, and critically elevated lactate. This patient obviously had sepsis, and it wasn't picked up early. And so the lab was called, and they said, "Hey, as usual, it's the lab's fault most of the time." Um, you know, they called and they said, the lab said, we reported it, but we didn't really report it because we didn't know who the nurse for the patient was. So this could really have been averted if the right things had been done and if the critical value was reported properly, right? So when you come to a life cycle of a test, there's so many things that happen before a test result appears in a medical record, right? Or a test result is handed over to you as a care provider. So first, the right test has to be ordered. For that, the right test names have to be given, right? So sometimes things like GFR. So there's something like epidermal growth factor is EGFR. EGFR is also creatinine, right? So glomerular filtration rate. So you need to know what test to order. This very, very commonly misordered tests are drug tests because it's not named properly sometimes. So you need to order the right test. That's the pre-analytical. There are a lot of, the Institute of Medicine actually in 2001 said that the most errors that happen due to lab errors are in the pre-analytical stage. 65% of diagnostic errors happen, medical errors happen because of pre-analytical errors, right? So it's our job with you all as to combine and collaborate and do the right thing for the patient, because this is not about blame games and about who's doing the wrong thing, but what is the right thing to do for the patient. So you have pre-analytical different steps, which is test ordering, patient specimen identification, collection in the right container. We talked about this morning about a pseudo hyponatremia and about a pseudo hyperkalemia, how you can avoid that if you know that hemolysis can affect potassium levels, right? So whether the specimen is collected and transported in appropriate time to the lab. And then most often labs nowadays have electronic medical record reporting systems. So at least right as soon as the test is reported, if it's verified and the specimen is fine, then it goes to the chart. So how many of you rely on different colors or up arrows or down arrows to say whether the lab result is abnormal or normal or abnormal? Truthfully. Okay, there we have one. Colors, yeah. So I mean, so that means it's the onus on the laboratorian and the clinician to make sure that the reference ranges are appropriate, that the ranges for the criticals are also appropriate, right? So why is it important? Because the patient is at the interface of the lab and the provider. When the provider, the healthcare provider, makes a diagnostic decision, it is based upon what the lab has reported as low or high, whether it's below the reference range, above the reference range, whether it is so high that it needs immediate attention and it's a critical value, or perhaps it's not that urgent that it has to be taken care of immediately, but perhaps by the end of the day. And that would be something called a medically urgent value, but not a critical value, right? So what is a critical value? What are the requirements for critical value reporting? There are many regulatory requirements, and the reason for the regulatory requirements is obviously because if there is an urgent decision to be taken care of for altering the patient outcome, then it's important for a lab to follow that. How do clinical labs actually establish critical value lists and appropriate thresholds? Who should make these critical value notifications? Who should receive them? What is the responsibility of the pathologist and what is the responsibility of the healthcare provider in this critical value process? So, the definition of a critical lab value is anything, any result that reflects the pathophysiological derangements at such variance to be with normal, such that it is life threatening. And so, if care or therapy is not instituted immediately, then it could be fatal. So, that is the definition of a critical lab value. And because of the critical nature of this lab value, urgent notification of the critical value to the appropriate healthcare professional is mandatory, right? And there are several different ways critical values are called, like panic values, alert values, etc. But again, the term panic refers to exactly what you shouldn't do, not panic when there's a critical value. You need to be, using all your senses to do the right thing based on the value. So it's discouraged to use the term panic value, but a critical value is something that needs to be examined critically, and patient is to be managed accordingly. So critical lab values are defined by every lab in collaboration with the medical team. It's important to limit the number of critical tests. You don't want alert fatigue, right? You don't want people calling you unnecessarily for things that you can wait for when the results come, right? So notification should be made to the care team, to a licensed healthcare professional. And I'll show you some studies where this is really not done. Most of the time in outpatient labs, it's usually the clerk at the desk that takes the call and sometimes doesn't transfer it to the appropriate healthcare professional, and that can cause a detrimental outcome. So there are clear standards, and I think most labs here are also ISO certified or NABL certified. And so they say that there should be a standard test report, and the test report should say the lab should immediately alert the individual or the entity requesting the test. So, for example, if you have an ordering physician, a charge nurse, whom should the test results be reported to? And is there an ongoing process as to whether this is done properly? Is it managed well? Is it reported on time to the appropriate person? And is the critical value limit actually appropriate? And so the guidelines are there. There is a written policy. It's defined as a life-threatening. So we talked about that. And how do you document the policy? So if you're following it, especially in the United States where we have litigations for everything and everybody can be sued, we have to have documentation that somebody has called a critical value to another person, not because you want to blame another person for a fault that has occurred, but because you can make it better next time and the patient will live, right? So who can receive the results? So receive the results can only be released to authorized persons who are responsible for using the test results and the laboratory that initially requested the test. So the documentation must have certain tenets. It should have the date and the time, the responsible lab individual that actually called the provider, the provider that was notified, or in an outpatient case, the person that was notified, and the test result itself. So transmission of these results electronically is acceptable, and the lab must confirm electronic receipt. And in case there is an electronic receipt, no readback is required. Okay, so these are the different things that need to be regulatory aspect of a critical value documentation. And who receives the critical values? It's like the Hollywood squares. It could be anybody from an RN to a staff nurse, to a medical student, to a trainee, to an on-call physician, to office staff. And this is why it needs to be appropriately managed. So how do you establish a critical value? So you have to discuss the list of tests that warrant the term critical, which means that if you have a high SGOT or AST/ALT, it's not going to be critical. It's going to be represented as a high or a low, and you have to look at it, but it's not a critical limit is not applied to the test. So what is the process that identifies the critical value? And when the critical value is called, what is the escalation policy? Is it received by a charge nurse and then the attending is notified? Or if the attending is not there, what is the policy for this? So that should be clearly documented in each of the departments. And how do you establish a critical value? So the birth of a new critical value always happens from a sentinel event or a series of events. You perform a root cause analysis, and if you identify along with the clinical team, management team, that this needs to be a critical value, then you would then establish this critical value, and then the medical staff will review it from all of the different divisions, because you as a lab can only have one critical value, right? You can't have one critical value for nephrology, another critical value for cardiology, and so that's going to cause a lot of confusion. So you do need to have all of the medical staff review your critical limit, and based on that, you call the critical, right? So, for example, there's drugs of abuse. If you telephone all positive results versus if you only telephone all the toxic values, the correction of that the patient outcome is different. So you do not want to call everything and have an alert fatigue, and one size may not fit all, right? So, for example, for a critical value in an inpatient setting, you want to call immediately within 15 minutes, right? But if it is an outpatient, it's not always possible to call within the 15-minute window. Sometimes, in fact, you receive the sample from the outside, wherever draw facility, almost 2 hours after you draw the sample, right? So you have an escalation process, and it is expected that even in the outpatient setting, as soon as you receive a critical, you call within 60 minutes. So that's something that you talk to your medical providers and come to that. So what about pediatrics? So for example, glucose, right? 45 to 450 is what we use. And the reason for that is that the way you treat a patient in a pediatric setting is different from the way you treat in a adult setting. The volume of the patient is different. The way that the patient responds is different. In a geriatric population, it's the same way. So you have to establish your critical values also based on what population you're treating, right? You don't want to be calling too many criticals. At the same time, you don't want to undercall the criticals such that so you want to play in the safe zone. So for example, this is a critical value that is approved by the medical staff at our institution at Texas Children's. And you'll see there are very defined tests. There are minimal tests, and we have the lower limits and upper limits defined. And we only call these tests, and this is something that we review annually and then we pull data retrospectively to see, is there anything that needs to be added to this list? Is there anything that needs to be taken away? And this is what happens. So again, calling the criticals to the providers, the notification methods have evolved from the pigeon bringing the lab test results to the telephone and the paging system. And nowadays you have obviously EHR embedded values. There are push notifications. And in at least at Texas Children's, we have secure chats. So you enable a push notification, and the first thing that you do is that the ordering provider acknowledges the notification. So you have it documented in the chart, and the appropriate thing is done for the patient. And in case that doesn't work, and say they've not seen their phone or their computer or whatever in the defined time, I'm almost done, then what we will do then is to go to the next step and do the calling, right? So there are different ways that you can do these notifications. And like I said, there is something called a critical versus a medically urgent alert. You have this presentation. I would welcome you to review some of the lawsuits that have been made based on critical values. And this is here a glucose that was a 300. That is really not a critical value, but then it was for this patient. And so is it important in certain settings to set medically urgent values rather than critical values and have a different way of communicating the medically urgent values to the clinical team? And what do you do if you cannot locate the provider? So does each department have a defined escalation policy such that the patient's outcome is not harmed? This is again a sample escalation protocol for an inpatient versus a patient that is discharged versus a patient that is outpatient during clinic hours. So at least you can reach somebody in the office and they can call the patient and say, hey, can you come in? Because I think this is a critical and we need to attack this potassium or this calcium value immediately, right? And you can have an outpatient after hours where there's an answering machine policy that will then call the provider or the patient itself to come in based on the critical value. So the last thing that I want to say is poor communication at the bedside does patient harm. And these are again many examples where the critical result is called to the nursing unit, but either it's not passed on to, for example, the cath team in the first patient. In the second patient, it was called to the wrong physician because in the electronic record, it was not the appropriate physician that was treating the patient. And the third case was a case again where the outcome was bad because the lab did not notify them. So this is a combined responsibility of everybody that is managing the patient, right from the radiologist to the laboratorian to the clinical team, right? And this is some of the critical review values that we monitor pretty much on a weekly basis. We look at them, and if, for example, this is a potassium where there was hyperkalemia, but the hyperkalemia was really because of hemolysis, and we had to redraw the patient and make sure that it's not a critical. So when such situations occur a lot, for example, if there's a poor draw, say the nurse drew the wrong order and an EDTA tube was drawn, then you know that you have a really high potassium and you'll have a really low calcium. So then we set an alert in our laboratory system saying that, hey, do not release if you have a really high potassium and a low calcium. Let's review the result before it's released as a critical. So these things that laboratorians do on an ongoing basis and in conjunction with the clinical team to have effective patient care. So in summary, it's important for critical values, important for patient management and outcome. Very important to have communication between the lab and the provider, establish an effective policy and monitor it periodically. And yes, there are several important regulatory aspects, but in the end, it is what is right for the patient. Thank you.
Thank you, ma'am. Thank you very much. As you rightly said, the provider gives the test, the great nursing team sends the blood, the lab has to report it correctly, because on everything depends the patient's treatment. So we have got a great team of nurses working for us. Let us give applause to them. Thank you, ma'am. So now operation is over. It may be a local, it may be a GA, it may be a regional, it may be a cardiac case, it may be a neuro case, it may be a multispecialty case. Operation is over, patient is in post-op ICU or just outside the operation theater. And sometimes the rhythm goes wrong. How do we react to this rhythm? Do we react to this rhythm, or what to do about it? We already know, ma'am, so we again welcome you, ma'am, to give a lecture on post-op arrhythmias.
Humble and loving pranams, dear Swami. Sairam again, everyone. So we'll continue with the topic of postoperative management, but switching a little bit here to postoperative management of arrhythmias. It's a very, very broad topic, so we're going to do sort of like an overview because there's no way we can talk about all the arrhythmias and how to manage every one of them. So our objectives are to identify basic post-op tachy and bradyarrhythmias, understand the initial post-op management of these arrhythmias, and then since everyone is trained in ACLS, we're going to look at the critical differences in post-op management of arrhythmias versus what we learn in regular advanced cardiac life support. So just to start, the incidence of arrhythmias post-op, and this is both post-op non-cardiac and cardiac surgeries, is very high as up to 20-25% post-op non-cardiac surgery. But if it's cardiac surgery, much higher. Post-op cardiac surgery may be as high as 50%. This varies a lot depending on the type of surgery, the duration of surgery, what sort of arrhythmia we're looking at the incidence of, how we're monitoring the patient, and what sort of surgery they've had if it's a cardiac surgery. The most common, of course, you've all seen is atrial fibrillation post-cardiac surgery, but then they can also have ventricular and supraventricular arrhythmias. And interestingly, despite the amazing developments we've had in cardiac surgery, in anesthesia, in post-operative care, the incidence of arrhythmias post-operatively has remained unchanged over decades. So it's here to stay. You're always going to need to do this. So what are the risk factors for development of post-op arrhythmias? There are a multitude of risk factors. So we're not going to go over all of them, but the most important ones, age. So if you have older patients going to OT, when they're going to come out, you're going to have a much higher risk of development of arrhythmias. Higher in males, higher if they have a lot of comorbidities, higher if they have, post-operatively a lot of acidosis, electrolyte imbalances, fluid imbalances, if they've had a lot of ischemia during their surgery, if they have a lot of we talked about the systemic inflammatory response during surgery, all of these patients will tend to have a much higher risk of post-operative arrhythmias. And when you're managing the post-operative arrhythmias, you have to take this into consideration, because if you don't treat the underlying cause of the arrhythmia, you're going to have recurrent arrhythmias. So while you're treating the arrhythmia itself, you need to know what the underlying causes may have been for the development of arrhythmias and treat that too. What about surgical related risk factors? Non-cardiac surgery, it's higher in thoracic than in like an abdominal surgery. It's higher if it's a longer surgery or an emergent surgery, or there were a lot of complications during the surgery, or if more blood transfusion was needed during the surgery, then they tend to have more arrhythmias. How about after cardiac surgery? Here, a lot dependent on the type of surgery, what they went in with. Did they have mitral valve disease? Did they have a lot of atrial stretch because of the mitral valve disease? Did they have an ASD repair? And then there's a lot of manipulation of the atria, so they can have a lot of atrial arrhythmias. And then it's lower if there's less manipulation, like a transcatheter valve, or if you don't put them on bypass, so like you have off bypass Lima to LAD type of surgeries. So then the risk is lower. So you need to take into consideration all of these risk factors when you're managing post-operative arrhythmias. So when we get a patient who has suddenly developed an arrhythmia, it can be a tachy or bradyarrhythmia. We're going to cover tachyarrhythmias first. If you have a tachyarrhythmia, the first thing you do is identify, you stabilize the patient first, and then you look and identify, is it a narrow complex or a wide complex tachycardia? To understand the difference, we need to know the conduction pathway. So the conduction starts at the SA node, which is the intrinsic pacemaker. It comes down to the AV node, which sits at the junction of the atria and the ventricle. Then it goes down this bundle of His, which is a common pathway, and then the bundle of His splits up into the right and left branches, and the conduction then goes to all the different ventricular myofibrils. So if your conduction is going through this native pathway down to all the parts of the ventricle, then it's going to be a narrow complex tachycardia. However, once this bundle divides into the left and right bundle, if the arrhythmia originates beyond this, then it's going to be a wide complex tachycardia. So what is a narrow complex tachycardia? Basically, if your QRS duration is less than 120 milliseconds, it's a narrow complex tachycardia. How do you look at that quickly? On your ECG, you have these tiny little blocks. Each one is about 40 milliseconds. So 3 little tiny boxes. If it's longer than that, it's a wide complex. If it's less than that, it's a narrow complex tachycardia. There are a huge number of narrow complex tachycardias. Once you have a narrow complex, you divide them into, is the rhythm regular or is it irregular? If it's a regular rhythm, it's more likely to be like an SVT. It could be a sinus tachycardia. It could be an atrial flutter. If it's irregular, it tends to be generally, most commonly, it tends to be atrial fibrillation. It can be one of the supraventricular tachycardias, the SVTs or atrial flutter with variable conduction, or it could be something like multifocal atrial tachycardia. So let's look at a few strips, and I'd just like you to call out when you look at the strip, what do you think this is? So what does anyone think this rhythm is? It's tachycardia. Is it narrow, wide, complex? Narrow. Is it regular or irregular? Just call out. It's regular. What do you think it is? It's an SVT. So this is a supraventricular tachycardia. Origin is above that bundle of hairs or in the atria. It's a supraventricular tachycardia. You could try and treat it with vagal maneuvers, carotid massage, adenosine. Let's look at another narrow complex tachycardia. What about this one? Compared to the previous one, do you see P waves over here? So just looking at it on a first glance, you don't see P waves. If you look at it closer, there's a little P wave after the QRS complex. What about here? Do you see P waves? Sort of tailing on the end of the T wave, you see a P wave over there. It's like a double hump, right? So this is not actually an arrhythmia per se, it's sinus tachycardia. Important to differentiate. In a post-op patient, easy way to differentiate, they're usually on cardiac monitoring. So if it's a gradual increase in the heart rate and tachycardia, that's usually sinus tachycardia. If it's a sudden increase, then it's more likely to be SVT. How about this? Looks fairly regular. What about the atrial activity? Do you see P waves? You see like a nice sawtooth pattern of P waves. So this is atrial flutter, where you have a nice sawtooth pattern of P waves and regular conduction for the most part. What about this compared to the previous slide? Is it regular, irregular? It's irregular. What about atrial activity? Do you see P waves? Here also you have a nice sawtooth pattern. So this is still atrial flutter, but with variable conduction down to the ventricles. Still atrial flutter. What about this, regular or irregular? Irregular. What do you think it is? Perfect. So this is atrial fibrillation, irregular. Either you don't see any P waves or you can see this very disorganized atrial activity. Don't mistake this for flutter waves. This is not atrial flutter. This is atrial fibrillation. It's just sort of disorganized atrial activity. Okay. What about, so that's narrow complex tachycardias, and we'll talk about management. What about wide complex tachycardias? So when you have a wide complex tachycardia, the thing which we worry about most is it a ventricular origin, right? Because if it's a VT, then they're likely to be much more unstable. However, you can get wide complex tachycardias which come from above the ventricle. So SVTs, atrial flutter, atrial fibrillation, they can also present as wide complex tachycardia if we talked about that conduction, but the conduction is, say, blocked in like the left bundle or the right bundle. So there's an aberrant conduction, right? Then they can still be wide complex, but they tend to be a little bit more stable than if you have a wide complex, which is a VT. It's a big talk to talk about how to differentiate. A good thing to know is if you have a preoperative EKG and you compare it to what you're seeing, and if the axis and the pattern of the QRS complex is similar, then it's more likely to be an SVT with aberrancy than a VT. Okay, and you can also get wide complex tachycardias just from like electrolyte imbalances. I know you had a great talk on that this morning. Okay, so what about this? What does everyone think this is? Wide or narrow? Wide, right? What do you think it is? Yeah, it's nice, regular, regular rhythm, wide complex. It's a monomorphic ventricular tachycardia. We're going to skip over this. Okay, what about this one? Oh, Oh dear. Okay. How about the first half of this? So we'll talk about the first half, which is similar to the previous slide. What about the first half of this EKG? Wide complex? Correct. Okay, so first we have a wide complex, and then you see this sort of undulation, right? Why high voltages, low voltages, high voltages, low voltages. That's polymorphic VT. And then this degenerates here to ventricular fibrillation. You usually won't catch this on a 12-lead EKG, hopefully. So this is another type of wide complex tachycardia, unstable. What about this wide complex tachycardia? So you have a good hint on the top. What do they do? Carotid massage, a vagal maneuver. What will a vagal maneuver work with? Will it work with VT? No, right? So this is an SVT with aberrancy. And the other thing I want you to look at is if you see the axis in each of these leads, if you see the axis of the QRS complex before the carotid massage and after, you can see that the axis remains the same. So the QRS complexes look similar, whether they're up more or down more. So the axis remains the same. This is a wide complex tachycardia, which is an SVT with aberrancy. Okay, so how about management? So first of all, we'll talk about if the patient is unresponsive and not breathing normally. Of course, if a patient is unresponsive, not breathing normally, you're going to go down your advanced cardiac life support protocol, right? So you're going to assess their rhythm, you're going to defibrillate if it's a shockable rhythm. If it's not shockable, you'll start chest compressions, epinephrine, and wait till you get ROSC. While you're doing all of that, you're still thinking about what was the cause and thinking about what you're going to do to treat it. And then once you've achieved spontaneous circulation, then you'll go to treatment of all the reversible causes. If the patient is not unresponsive and is breathing normally, then we look at whether they are hemodynamically stable or not. And then if you have a tachycardia, which is hemodynamically unstable, forget about narrow complex, wide complex, they're hemodynamically unstable. Of course, you have to cardiovert them. Cardiovert them, give them a high loading dose of amiodarone, and then look for reversible causes. If they're stable, then we can start to assess whether it's a narrow complex or wide complex and treat accordingly. What are the reversible causes? It's not wanting to proceed. Okay, there we go. So reversible causes you need to be thinking about when you're treating your arrhythmias: hypoxia, hypovolemia, electrolyte imbalances, acidosis, whether they are hypothermic, hyperthermic, do they have thyroid issues, is there an infection, is it because of drugs? Sometimes you can give them too much inotropy and you can get arrhythmias. Are they on any other proarrhythmic drugs? Is there tamponade? So you assess for all the reversible causes, because if you don't treat that, you're going to have recurrent arrhythmias. And then if they're a hemodynamically stable patient, then you can go down the pathway. Is it a narrow complex or a wide complex? Is it regular or irregular? And then based on that, you can try and determine what the underlying rhythm is and treat it accordingly. Okay, now switching gears, we'll talk about bradyarrhythmias postoperatively. There are two main bradyarrhythmias postoperatively after cardiac surgery. The first one is any sort of sinus node dysfunction, right? So sinus node dysfunction is usually a combination of there's some degeneration of the sinus node or atrial tissue or surrounding the sinus node tissue. And then there are some additional insults, some additional reversible causes. Like, do we have them on beta blockers? Are they hypothyroid? Do they have raised intracranial pressures? Do they have an electrolyte imbalance? Did they have surgery on the atria and there's some inflammation around the sinus node? So a reversible cause, and there's usually some underlying disease of the SA node. When they had surgery, was there trauma to the node or even the artery supplying the SA node? So we want to correct the extrinsic causes and treat the bradyarrhythmia. So when treating the bradyarrhythmia, you can use positive chronotropic drugs like atropine, isoproterenol, and then the other option is also pacing. If it's sinus node dysfunction, you prefer atrial pacing so it can go down the native conduction. The other type of bradyarrhythmias which you have postoperatively are blocks. So there are different types of AV blocks. This is I mean, don't even really consider it a block, but it's a first degree block, just a prolonged PR interval. What is the second one? This is Wenckebach. So you see there's a dropped P wave. The easiest way to identify is look at the PR interval before and after. Longer PR interval before than after the dropped beat, that's Wenckebach or Mobitz type 1 block. What about this? Higher grade block, you have a regular PR interval and then you suddenly drop a beat. More dangerous than the Wenckebach, right? Mobitz type 2 block. What about here? Regular P waves, regular QRS complexes, but no association between the two. What is this? This is complete heart block. So all of these we will see post-operatively. How do we manage post-operative AV block? So this is a little bit different to AV block when you've not just had surgery on your heart. Many times when you have a post-cardiac surgery AV block, there will be a reversible cause. So it may be because you've just operated on the atrium. You have to consider if they're on drugs, because a lot of these patients were treated for their tachyarrhythmia, so they may be on drugs to lower their heart rate. And so we'll try and treat the underlying cause. But if the AV block persists, especially if it persists for more than a week after surgery, then we need to start thinking about, do they need a pacemaker implantation? Post-TAVI, if they develop AV block, probably they won't recover it and you would consider pacemaker implantation. And then other causes just really depends upon the reversibility. It's a little bit different managing AV block post-op than if it's just in a regular patient with AV block. How about pacing these patients? So these patients often require temporary pacing. Most of your patients, when they come out of the OT, they're going to have some temporary wires which you can use to pace the patient, right? So these are temporary methods of pacing. You can go transcutaneous, terrible, very painful for the patient, should only be used for a very short time. Transvenous, also risks of complications. Epicardial, a lot of our patients come out with wires, so you can do epicardial pacing. Transesophageal, not used that much. You only use temporary pacing if there's a life-threatening condition, which you think is going to be short-lived and reversible, or as a bridge to a permanent pacing device. You can also pace in some rhythms like torsades, where if you pace at a high rate, then you can prevent recurrent episodes of torsades, because torsades is a rhythm which is sort of dependent on slower heart rates. So there's another indication for pacing. And then briefly, we'll just look at cardiac arrest after cardiac surgery, because it's dealt with very differently from cardiac arrest when there hasn't been cardiac surgery. The reason is most of these occurrences of cardiac arrest after cardiac surgery, which happen usually in the first 5 hours post-operatively, are due to reversible causes. And that's why survival rates of cardiac arrest after cardiac surgery are a lot higher than survival rates of cardiac arrest otherwise. Just another 2 minutes. So usually you won't initiate compressions immediately, because then you can rupture the repair. Epi is given in lower doses, and you prefer to pace them if they arrest over giving them drugs, which will increase their heart rate. And most of them have pacing wires. So when you have an arrest after cardiac surgery, you identify the rhythm, but mainly you do all of your shocks. And if you don't recover immediately, you can do external compressions. But the aim is to reopen the chest within the first 5 minutes and give an internal cardiac massage to resuscitate the patient and give internal defibrillation. So cardiac arrest after cardiac surgery, good survival rates, but very different management. Okay, so in conclusion, post-op arrhythmias are common. We have to look carefully for underlying reversible causes. And then we looked at the post-op management of tachy and bradyarrhythmias, and then the differences between this management after cardiac surgery with ACLS. These are my references. Thank you, Jai Sai Ram.
Thank you very much. Thank you very much. It was a very nice lecture. I hope all of you understood. Next time you'll remember when to call and when not to call. Now, too much of critical care has happened, so let us go to an interesting case which Dr. Mohan is going to present. So I request him to present. You know, all of you know him. He gives a very nice lecture. So let us here to the interesting case here which is presenting. After all the lectures, we are going to have a small quiz. The questions are going to come from all the lectures which you have heard, I hope. So whoever answers correctly is going to get a small gift. So be ready for and listen to it carefully.
Um, very good afternoon now. So, I'd like to share with you some of very common but not very well understood poisonings which we have encountered. And like I said earlier, I have no conflict of interest to declare. Acute deliberate self poisoning is a common cause of ER visit. In fact, 60% of our workload, especially during the times of stress, like exams and other such things, we get a lot of patients with acute deliberate self poisoning. And obviously, after the ER, they are moved to the MICU. There are a wide spectrum of causes, very innovative, very cheap. Like, for example, in Bengaluru, I think, like in Tirupati, you can just walk down and buy one of the poisons I'll be discussing from any fancy shop, from any retail shop. And just one capful, one Udrani Tirtham can kill a marriage party. So these are deadly things that I think probably many of you will be using it also. Maybe I shouldn't give you the ideas. Okay. There is a good local regional variation with regard to the poisons which we encounter. For example, in Delhi, where I trained, aluminum phosphide poisoning was most common. It was a wheat preservative, rodenticide, and every other patient would be aluminum phosphide. And organophosphate compounds are more common in South India, but the trend is changing. There are not too many pesticide shops. If I ask you where can you buy pesticides in Bengaluru, I'm not sure whether you will be able to remember. But if I ask you where you can buy Pond's powder or snow, you will immediately tell me 100 shops. Okay, the diagnosis of poisoning is often based on circumstantial evidence. Madam's labs won't run to us to tell that this is so and so. It's circumstantial evidence. And point of care diagnostic tests are not available. The management is also individualized. It's like going to a tailor and getting your dress fitted because there are no consensus guidelines for this. So, with this introduction, let me deal with two common poisons and one envenomation, which is very common in Andhra, Karnataka, and Tamil Nadu. It's a very common poison. And I start with Clistanthus collides. It's called Vadishaku in Telugu. It's Kadise. And there is some other name which starts with B, I'm told. I was inquiring, what do you call it? It's a very common shrub. You go back in your residential area, residency, colony, you carefully see, you find it everywhere. Very convenient. Many people used to grow the karivepale, which you use for chonk. You just go pluck a few leaves. Pluck a few leaves, make a decoction, drink and die. So I call this a very deadly poison, and it is very commonly encountered suicidal poison. All the plant parts are poisonous, mortality in the best centers is 30% plus, and death occurs within a week. So, what are the toxic active principles? Some HPLC work has been done to identify these agents, but it is important to remember more than this that mortality usually occurs due to cardiac arrhythmias, acute kidney injury, shock, and respiratory distress. The mechanisms of toxicity are not clear. I share with you some earlier published work which has been further updated in view of our current experience. We again had the good blessings of Professor Guntupalli madam, who has been instrumental in inspiring us to do critical care in difficult circumstances. It's not a paying branch, it's not something which anyone is interested, but we are there inspired by madam. And this journal is published by ICMR, and it has an impact factor of 5. Impact factor 5 plus for those in the business is something. Briefly about the management protocol, all the patients received gastric lavage, activated charcoal administration, not always available. When in stock, we use, when in not, we pray. Intravenous fluids, ventilation, treatment, standard treatment of shock, dyselectrolytemia, and management of arrhythmias. So, who preferred this poison? These patients were in the 4th decade, going on to 5th decade, and the male-female ratio was more or less similar, and most of them consumed the leaves of the poison, and the time lapse from consumption to reaching casualty was, the median was 24 plus hours. It's just like your household shrub, you just pluck it. Nobody notices the person is unwell. They come late, a day late. And what are the cardinal manifestations? We have acute kidney injury, we have metabolic acidosis, respiratory failure requiring mechanical ventilation, peripheral circulatory failure and shock, neuromuscular weakness, and arrhythmias. If you see a combination of AKI with respiratory failure, often with unknown etiology, nobody will tell us the etiology. They don't come with a rubber stamp. I have swallowed cholestanthes. So you have to really squeeze out the information from them. The median Apache 2 score at admission was 4 with a range of interquartile range of 1 to 12. These patients stayed with us for about 2.5 days. The total hospitals ICU stay was 2.5 day, hospital stay was 4 days. Those who survived, we could pull them off, and the duration of mechanical ventilation on an average was about 10 hours. We, of the patients seen by us, 60% had survived, 40% have died. Considering those who have gone lama, we used to call it lama dama, left against medical advice, discharge, because it is cheaper to transport a person in a cab than transport a body in the mortuary van or a dicky. So when you are Siva, you sit in the car or lie down in the car. When you are a Shava, you are in the dicky. This one ikaram. So we take life for granted. So in this paper, it was a very interesting analysis when we combined the dead with lama. Those who go lama die. So it's do they do in the West? I don't know, but in India they do. So it's a kind of modified intention to treat analysis. Madam gave the name worst case scenario analysis. The credit goes to her, and that is now this is one of my most cited papers for the worst case scenario analysis. And our ethics committee, we told them that this is this. They agreed. We are lucky that way. Okay. So when we looked at those who survived and those who died, age-wise, not much difference. Time lapse, not much difference. But those who had died had a significantly higher Apache 2 score. Apache, there is Apache 1, 2, 3, 4, like Bahubali 1, 2, 3, but they have not really been validated in India. These have been evolved in the ICUs in the US and Europe. But it is This paper is also cited because when someone does a meta-analysis for the application of these critical illness scores in a third world country, these papers are cited often. So the time lapse slightly longer. P was just about less than 0.05 in those who died compared with those who were alive. And no, don't try to read that. This is a univariate analysis of the various categorical yes-no variables kind of in between the alive and dead. We didn't regress this data because the regression with a number of 57 is mathematically correct, but it is not the appropriate application of science to prediction rules. So what we found was occurrence of shock, acute respiratory failure requiring mechanical ventilation, elevated ALT, metabolic acidosis, acute kidney injury, hyponatremia, and neutrophilic leukocytosis. When these were there, any patient with Clistanthus poisoning, who it is often a misdiagnosis. So one should think of a sick one. So if we apply the international program on chemical safety poisoning severity score, there is a very rugged score, IPCS, CSS grading. As the score increased, the likelihood of death increased. The idea of sensitizing people is it is a misdiagnosis. Take a good history. Where do you live? What is the environment? Do you have plants and trees? Like that. So that is one. So when we compared with what we had done with the other studies, major things were different. But the occurrence of dyselectrolytemia, acute kidney injury, and shock, they were the predictors of death. So these are the other big studies, and our studies also has got a good number. So this I move on to the next. In next 5 minutes, I will try to complete a die to die. You play dice, Vaikuntapali. So this is a die to die. I'm sure everyone knows Keshkala 3-3. Super vast small Keshkala 3-3. I shudder to die because I may die. So I prefer to be salt and pepper. So this is a very deadly poison. You just go out of this institute, first shop where you can buy scent powder, soap, you ask, they will give you Keshkala, free of cost. One cap is finished. One cap, kill a marriage party. Okay, so death usually occurs very shortly, and the mortality is high to the tune of 60%. Very popular. Pesticide is painful to go and buy, kerosene smell and all. Nothing. Just take one chota, then you're gone. So it is a PPD. What is PPD? Paraphenylene diamine containing dye. So that's what I had shown here. That little chemistry. It is a paraphenylene diamine containing dye. And that is, it's not only popular only in our friendly neighborhood country, but in Iran, Iraq, and the Gulf countries, everyone wants to look young and charming. So Keshkala is an essential requirement. So this is all the mechanism. If you accept it is there, it causes acute kidney injury, myocardial toxicity, arrhythmias. That's what if you get a combination of arrhythmias and AKI in a patient with poisoning, think of this paraphenylene diamine containing hair dye. So we studied 234 patients who presented to our service. The management protocol is very unusual. This is one of the situations where we don't intubate. Instead, we do a cricothyroidotomy or a T-piece ventilation, because you can't enter the larynx. Larynx is swollen. If you struggle and create a pathway, all complications madam showed in the morning, tracheo, aortic, tracheo, blah, blah, all those fistulas will develop. So this is one situation. You either immediately you do a cricothyroidotomy, and then you access the airway and give a T-piece ventilation. Very rare, very in small number of cases only you actually need to intubate. Why, I will tell you. There is a massive cervicofacial edema. Massive cervicofacial edema, and the airway is edematous. Face is swollen, airway is edematous, and accessing the airway is the trick. If you get through that, if you support the kidney, if you treat the arrhythmias, you can pull out the patient. Treatment of shock and renal replacement therapy and all are well known. So again, this is a preferred one for the young woman. Men like to look older than women. Women like to look young. That's what everyone says. I asked, why did you use this? Why did you keep it in the house? I'm graying. I can't stand one gray hair. So this is a woman poison. And presentation commonly cervicofacial edema. I will share some images. Acute respiratory failure requiring not ventilatory management, airway management. Those who know, they handle it. Those who don't know, you struggle with the tube. By the time you secure the airway, patient has gone. Vaikuntha Ekadasi. Then you have acute kidney injury, arrhythmias. These are the three killers. So this is a lady. This is how she presented. Big swollen face. This is the urine on day 1. ATN, acute tubular necrosis. High colored urine. Urine on day 3, day 5, day 14, which was the day of discharge. Urine became normal. Massive, see in the neck, there is a TP's ventilation going on. We didn't ventilate, we didn't intubate this patient. That was the picture on day 1. This one passed away. Before we could say 1, 2, 3, she passed away. Very sick patient, half bottle she drank. So they don't give us the chance. Please remember, hair dye poisoning, swollen face. Not many poisonings are like this. Swollen face, laryngeal edema. Cannot talk because of laryngeal edema. When did you take? I'm a doctor. Then there's no need to take detailed history. It is self-explanatory. This is one of the patients we lost. So 131 out of 234 patients required airway management. Tracheal intubation 34%, emergency tracheostomy 22%. Total 131 of them needed. Assisted ventilation overall in 37%. TP's ventilation, tracheal intubation, tracheostomy plus all together is this. So more than one modality. Sometimes you immediately secure the airway. After 2 days, you may convert it to formal tracheostomy and then ventilation and so on. That depends on case to case. So time lapse 13 hours. They do rush earlier than Clestanthus. Duration of MISU stay 4 days. Total hospital stay 6 days. Ventilation hours 48 hours. If they pull through, they usually pull through early. And again, the 68% survived because we learned how to. No book gives this. You use any, check out any toxicology textbooks of the white man. Nothing is told about this. So then dead plus lama is this. So what were the predictors of mortality? We had done a univariate analysis, a higher Apache 2 score, then the presence of arrhythmias, AKI, acute respiratory failure, and so on. Some laboratory abnormalities were also there. But when we did a stepwise multivariable logistic regression analysis in the forward conditional method, the need for ventilation and AKI had emerged as predictors of death. We compared our study. Our number is humongous. The Stone brand hair dye was reported from Jhansi, and what we had seen has been similar to what others have reported. Only that we did the multivariable analysis for predictors of death. In other things, it was narrative descriptive. One last word about the Indian red scorpion, the Mesobuthus tamulus, deadly in children, they drop dead. For drop dead looks, you take the hair dye. For dropping dead, you get stung by these. Many students, I don't know, students in the exam, when we ask them, they tell scorpion bite. We bite with our teeth. Scorpions don't have teeth. So it's a scorpion sting, not a bite. Okay, scorpion sting in adults is also common. And the patients usually present with extreme anxiety, severe pain at the bite site, breathlessness. They present with shock, hypotension, pulmonary edema, elevated CP and CPK, renal parameters and all, with a wide range of this arrhythmias. Many people use prazosin to treat those who are not in cardiogenic shock. They say when you are in a village, you walk with prazosin tablets in your pocket. You get stung, something remotely like a scorpion, swallow it. It's there, but the patients we have seen are those with toxic scorpion sting envenomation, myocarditis. So, as they say, there is a very famous poem by the poet Srinatha. Some of you may understand Telugu. So in Palnadu, where he used to be there, he used to say, చిన్న చిన్న రాళ్ళు చిల్లర దేవుళ్ళు నాగులేటి నీళ్లు నాపరాళ్ళు సజ్జ జొన్న కూళ్ళు సర్పంబులు నుత్తేళ్ళు పల్నాటి సీమ పల్లెటూళ్ళు. Our villages are still like that today. Concluding remark, I quote Sir Arthur Conan Doyle. Incidentally, Arthur Conan Doyle reported Robert Koch's discovery of M. tuberculosis to the newspapers. Medical doctor Arthur Conan Doyle was a newspaper reporter, uncorrected to poison, materia non-medica. Okay, so when you have eliminated the impossible, whatever remains, however improbable, must be the truth. So that's what we do, unfortunately, when we treat poisoning in a small town like Tirupati. And I'm sure that is the case with a big town like Bengaluru also. So it is more of a hunch, a clinician's hunting instinct, and a careful look for the critical history, typical presentation. That is what we need to actually pick up the diagnosis early and get going with treatment. If the chair permits me, I'll read a couplet and conclude. I'm very passionate about this because everyone is taught Hippocrates' oath. Nothing wrong with that. But Rantideva is a very famous emperor who is referred to in both Vyasa's Bharata as well as Bhagavata. He is known for his Tyaga Guna, the ability to give up. Like Shibi, like Bali, not like that deadly quartet Karna fellow. He is in a different league altogether. Once God appeared before him, he was so pleased with his Tyaga Guna because Tyagaenaikam Amrutatva Manasu. He was asked, what boon you want? I'm very impressed with you. I'll give you something. He said, Natvaham Kamaye Rajyam. He's an emperor. All Alexander wanted more land to conquer. No, I don't want Rajyam. Naswargam. I don't want to go to heaven. Punar Bhavam means Bhavam is happening. Punar Bhavam is rebirth. Punar Bhavam. In Sanskritam, if you put A before, the meaning becomes opposite. Punar Bhavam is absence of rebirth. He doesn't ask for moksha. Punaravritti Rahita moksha. He asks for Na Apunar Bhavam. Then Bhagavan became crazy. He said, what do you want? You don't want land. You don't want to go to heaven. You don't want Apunar Bhavam. What do you want? He said only one thing. Kamaye dukkhataptanam praninam arti nasanam. Arti is suffering. Give me the ability to reduce the suffering of any living being. He didn't say man. He said Praninam artinasanam. Vrkshesu, Dvipadeshu, Chaturpadeshu. Samno astut Dvipade, Sam Chatushpade. Let me reduce the suffering. I think every medical student should be taught this. And I thought of taking the liberty with Indian stretchable time to go overboard with this, because if in this highly spiritual place people don't see the spirituality of medicine, look at only the number crunching, then that is not dharma. I conclude here. I apologize for rescheduling a very senior colleague and faculty like madam to speak out of turn early and to eat away. I'm not a Maikasura generally, but today I had to speak because to me this is very close to my heart. I am practicing what I am practicing like this. Thank you very much. And God willing, this is my first visit to this place. There is intrinsic, highly elevated spiritual feeling. and God willing, well, I may come again. Thank you and namaste.
Thank you, sir. We are humbled to have you here. It was a really wonderful eye opener and a very nice lecture. I hope you have a nice, safe journey back.
I'm
Uh,
sorry about going overboard with spirituality, but I think we all need, post COVID, we learned that we are not sure of being alive next minute.
Thank you, sir. Thank you very much. I request our own Kalpalata madam to come and talk about dyspnea on ventilator.
Ma'am, you have a pen drive, ma'am. It says there's a problem, but it's opening. Yeah, that's it. You want to take it?
Yeah, I'll take it. I need it. Okay, I'm back again. So we're just going to do again some cases of a patient who's on a ventilator and who's kind of in respiratory distress. So when you approach this topic, one thing, there are several ways of describing when patient is short of breath or has respiratory distress. Sometimes it's also known as bucking the ventilator, that he's fighting the ventilator or bucking the ventilator. So important thing to know is when does it occur and what are the causes and how do you sort out and come to a reasonable diagnosis, because as you know, patient cannot tell you what's going on. They're sedated, they're intubated, they can't talk. And what are some of the management options and how do ventilator data and mechanics, which we don't go into that very much. So when is this happening? When is this patient dyspneic or short of breath? Did it happen immediately after intubation, or patient is on full ventilatory support for a day, two, whatever? Is this happening? Or is the patient getting more symptomatic when you're trying to wean the patient? Or patient is not doing well, you just extubated and patient is very short of breath and is snake? Or is it related to any other events? Remember that in the ICU we are doing so many things to the patient, so many people, sometimes two or three people are working on the patient. So we really don't know what is going on. Sometimes if the patient is very sick, sometimes we may have two nurses to a patient, three nurses to a patient, depending on how many life support systems are there supporting the patient. So when they're fighting it, there's another name also called patient ventilator dyssynchrony or asynchrony. So there are a couple of things you need to consider. Is it related to the ventilator or is it related to the patient? Some of the ventilator related factors are like, water in the tubing. I see it all the time. Just last week we had, that's one ventilator tracing. I have to take a picture. It may be, I may have 100 pictures, but I just love that and pneumothorax. I have to take a picture. So other things are like, the causes, the ventilator dysynchrony or asynchrony, we divide into three. I won't go into that. Usually a trigger dysynchrony or flow dysynchrony or cycle, which is expiration, when the exhalation happens. So it may be any of those and several causes for that. What about patient related causes? Why the patient may be fighting? So it can be respiratory center, for example, abnormal respiratory drive like Cheyne-Stokes breathing. Sometimes you will see that the patient is breathing very fast and you go there, then the patient is not breathing as fast, because patient may have Cheyne-Stokes breathing. Artificial airway or natural airway problems. Artificial airway problems, you may have a cuff leak, mucus plug, secretions, cuff herniation. Natural airway, bronchospasm, secretions of plugs, we saw some. And in the lungs itself, atelectasis, pneumonia, ARDS, congestive heart failure. Very importantly, what we call dynamic hyperinflation or auto PEEP, particularly patients who are acute asthma or COPD. Because they have auto PEEP or dynamic hyperinflation, that the ventilator does not know that there's so much positive pressure at the alveolar level, then the patient has to really struggle to get a breath. They have to overcome all of the auto peep and pull negative, minus 10, minus 20, depending on how much it is. So patient may be very restless. This is a very unrecognized, under-recognized cause of patient ventilated asynchrony. Pleural causes, pneumothorax. Somebody may have just attempted a line. Patient may have pneumothorax or spontaneous pneumothorax on a ventilator. Large pleural effusion, hemothorax, and diaphragm. You can have hiccups. There is really no glottis to closed for them to produce a sound like a hiccup, right? Because there's an endotracheal tube. But the hiccups are nothing but purposeless spasmodic contraction of the diaphragm. So when there is a hiccup, machine thinks patient wants a breath and it can give a breath. So, patient may be hyperventilated. Or there's something called diaphragmatic flutter, very very under recognized. People don't realize that, and that may cause some sort of dysynchrony. Or maybe chest wall and abdominal wall stiffness called wooden chest. Sometimes you may see that. Or you may have abdominal stiffness, compartment syndrome, distension, full bladder, and anxiety, and so all these could be. So the most important urgent question is, how stable is the patient, and is the patient having an impending arrest? Suppose you see a patient that is struggling to breathe, and what is the thing you would do? First thing, what do you want to do? Nurses can, you are at the bedside. What is the patient is on a ventilator, struggling to breathe. You think they may have an arrest in the next. What is the first thing you'll do before you call the doctor? Huh? So you'll try to suction, and then what else? Bag the patient. Correct, right? Do you think with your hands you can give more tidal volume than the ventilator? I can put a liter on the ventilator. Do you think you can do more than that? You cannot. But why is it that important to do that? Because when you have so much of plumbing, like between the ventilator, there are so many connections. There's maybe a nebulizer, there's inspiratory circuit, expiratory circuit. Whenever a patient is crashing, not necessarily respiratory wise, blood pressure is falling, whatever is happening, if they're on a ventilator, first thing you do is disconnect the patient, bag with 100% oxygen, because it's your hand, one connection to the endotracheal tube, right? So you can assess, is the lungs are stiff to bag? Am I able to bag or not able to bag? And so that is probably the first thing you need to do. Okay. So it's not that you're going to give more oxygen or more tidal volume with your hands. Machine can do just as well. But here that you are minimizing all the connections, and you can probably get some sort of an estimate of what's going on with the lungs. So what are the causes of, if it happens immediately after intubation, what are some of the things that you will think? You just intubated the patient is very restless, short of breath, whatever. What do you think? The three things that can happen if they got into distress. One is mainstem intubation. You may have one lung may be not being ventilated at all. Usually it's the left lung because the right tube goes into the right side. So the second one is that you can listen to the lungs and maybe pull the tube back, or if you have a bronchoscope, you can retract it over a bronchoscope. Second thing is dynamic hyperinflation, because especially like patients with severe asthma or COPD patients, they are really crashing and you intubate the patient. The first instinct of anybody, the respiratory therapist, to keep bag very fast, because they may have seen a blood gas with PCO of 100 or 70, pH was 6.8 or 7 or whatever. So the first instinct is to bag very vigorously. And these patients cannot exhale. Their problem is exhalation problem. So they cannot get rid of the air. So the more you do that, then they are trapping air. So that's called dynamic hyperinflation or autopede. And then you're going to drop the blood pressure. Patient can even have a cardiac arrest. So nobody ever dies of hypercapnia as much as they die of hypoxia. So don't take it easy. You don't have to bag as much. connect to 100% oxygen, so they're going to be, oxygen is going to be okay, so you don't have to hyperventilate the patient. Third thing that can happen is pneumothorax. Pneumothorax obviously can happen anytime, okay? But suppose you did a mainstem intubation, or patient has COPD, or bullous disease, or whatever, you can cause pneumothorax anytime. How do you sort it out? If patient is crashing right after you intubate, and if you want to sort out these things, one of the things, you can stop bagging, and if the blood pressure comes up, patient gets better, then it may be dynamic hyperinflation. You may have bagged so much that you're trapping air in the lungs. Leave them connected to 100% oxygen. It's called apnea trial. Like I said, nobody dies of apnea. So you just stop, and then they may get better. Second thing is, if you have like we have a lot of portable bronchoscopes that we have, disposable ones. So you can just take a quick look. And if it's tube is above the carina, you excluded mainstem intubation, and at least that's the main, before you wait for X-ray or whatever. And the third thing is, if you have ultrasound, which they're doing ultrasound workshop, you can see if the patient has pneumothorax. That may be a quick way of if there's lung sliding or not. So there are quick ways of sorting out before you call an X-ray or go for more investigations. So when the patient is on full ventilatory support, like they've been on it for 2 days, 3 days, 4 days, again, pneumothorax can happen anytime. Secretion in the mucus plug is what you worry about, and you've seen some case examples, and this we see it all the time. Another thing that comes into play is improper ventilator settings. And there's so much plumbing in the ventilator that I will sometimes say that patient is better off extubated than intubated. If the settings are wrong, patient is struggling to breathe. They're better off without the ventilator and the tube than having it. Water condensation quite common. So when you're attempting to wean, you're trying to wean the patient, and you went from full control mechanical ventilation to pressure support, or something very low mechanical ventilation, mechanical ventilator breaths. Sometimes if patient has very bad heart failure, the controlled breaths or mechanical breaths decrease the left ventricular afterload. So they may have, crash when you are actually trying to wean and extubate the patient. And maybe you're premature weaning when maybe patient is not ready. That may be, or maybe having other issues like MI. So if you immediately extubated the patient and patient is crashing right after, as soon as you extubated, that it may have to do with upper airway, like, laryngeal edema, spasm, probably less common than, upper airway edema, and vocal cord dysfunction, vocal cord paralysis, laryngeal webs, or stenosis. But, when you have tracheal stenosis post intubation compared to post tracheostomy, these are very flimsy and like strands. They're called like webs. You may see that, or tracheal granulomas, and granulation tissue, and tumors. So we'll just, with that background, we'll just go to some cases. So this is a patient actually who was in, who I was called for abdominal distension. This is a real case. Abdominal distension. Patient was had ARDS, had bilateral diffuse infiltrates, and has been on ventilatory support for 4 days. And nurse noticed that there's an abdominal distension. So this is the X-ray of the patient. Do you see, anyone wants to say what this is? Is it white or black? White on which side? Left side. Is it white on the right side? Or is it black on the right side? Huh? It's black and white. Very good. So you have white on this side because patient had ARDS. So, lungs are full of stuff. So on this side, you see a white, right? And surrounded by a lot of black. And you see actually the fenestrations of the diaphragm, the muscle fibers, that actually diaphragm is being pushed down. Normally, diaphragm should be what? Like on this side, it should be up here, right? The right diaphragm. Look how much it is. So the patient did have abdominal distension because the diaphragm was so much pushed down from tension pneumothorax that this patient had tension pneumothorax, and this is the collapsed lung. Again, it didn't go down all the way because it was full of fluid because of ARDS. So this is Something you do not want to miss. This is something you always have to think at all stages. And if you miss it, you can actually, it's detrimental to the patient, something you don't want to miss. The incidence of pneumothorax on a mechanical ventilator can be anywhere from 7 to 13%, depending on how bad the underlying lung is. If you have like severe asthma or interstitial lung disease or bullous lung disease or something, that's called secondary spontaneous pneumothorax, and you may have more predisposition for that. So why is pneumothorax, why is it that it's so critical in the ICU compared to maybe patient on the floor or outpatient? Or why do you think it's very important in the ICU patient? Any guesses? Any guess? If patient is on a ventilator and you missed a pneumothorax, why is it so important? Not to miss it. You shouldn't miss on anybody, but these patients are special, right? Okay, on positive pressure ventilation, right? Even a small pneumothorax can get bigger anytime, and then you don't know. So sometimes they'll say, "Oh, it's only 10% pneumothorax. Let's just watch it." But then, in the middle of the night, the patient is hypotensive, or you don't know. It may not be the pneumothorax that got bigger. And are you going to keep on getting X-rays or pull the ultrasound or whatever? So even a small one can get bigger at any time. Second one is it's very hard to diagnose. Okay. So you almost, these are the, if in a supine patient, remember the air goes to the top of whatever it is. So when the patient is lying down, it goes under the sternum. I'm lying down, it goes under the sternum. So it's not very typical to diagnose or to pick up that this is happening. So almost in a supine patient, you need almost 500 ml of pneumothorax or air in the pleural space to diagnose it, because it's not so easy to diagnose. In an upright, like somebody come to emergency room with a shortness of breath, and if there's pneumothorax, you can diagnose with 50 ml because you're standing up and it's up here and you always look there anyway for pneumothorax. If you do lateral decubitus, that's something at your disposal if you don't have ultrasound or somebody skilled to read the ultrasound. Lateral decubitus is a good way to diagnose. Even as small as 5 ml, you can diagnose. So air does not accumulate in the typical position. Discrete pleural line may be absent. So anteromedial line is the most dependent in supine position. So this accounts for 40% of pneumothorax in these patients. And I'll show you some signs that are there because of that. So POCUS is very helpful because you can do it like, now, an hour from now, 2 hours from now. It's not like X-ray, you have to ask somebody, you can, if you have the skills. So normally you'll see a white visceral pleural line, straight or convex towards the chest wall. This is how you will see it. And no vascular markings. What are some of the subtle signs in a supine patient? Okay, this is pneumothorax, and the lung always comes to medially and posteriorly when it collapses. So this is how it will collapse. So there's something called deep sulcus sign, especially in the patients in the ICU. And if you see this, you should be thinking of it. Because remember, I said when you're lying down, it goes medially and right under the sternum. So this is called a V sign of Nigleri. This is where you may see very subtle pneumothorax, small pneumothorax. Sometimes you will see it under the lung. And if the patient is a trauma patient, sometimes we see if there's a bronchial rupture, the bronchus is actually fractured and disconnected from the tracheobronchial tree. And what happens is, remember, if the lung is connected with the hilum, it will collapse posteriorly and to medially. But in this call, it is called a fallen lung sign, where the lung collapses and doesn't come back to the hilum because it's fractured. So it's called a fallen lung sign. Okay. What about this? What do you see in this X-ray? Any guesses? Left side, right side? Can you see it? What do you see on the right side or the left side? What do you not see? Okay, the heart is here, and you see this big thing with no lung markings. Do you see it? And there's some here. And this is a lateral film. So you see this big black space. This actually, they were about to put a chest tube on this page. This is a large giant bulle. This is not pneumothorax. This is a COPD patient with huge large bullous. Okay. So sometimes it's hard to distinguish. If you put a chest tube into this, you'll have a bronchopleural fistula. You'll never be able to, close this because it's actually in the lung. Okay, this is a deep sulcus line, right? Sign. This is the sign. This is pneumopericardium. Another sign of this is pneumomediastinum, and this is subcutaneous emphysema. And there's something called a continuous diaphragm sign, which is an interesting sign. It's a sign of pneumomediastinum. What you see is normally you see left diaphragm and you see right diaphragm. The reason we don't see anything underneath is because the heart is sitting on the diaphragm, it cancels the shadow. When you have pneumomediastinum, this is called a continuous diaphragm sign. It looks like it's one diaphragm. You see this? It looks like its diaphragm is continuous. That's because there's air in the mediastinum underneath the heart. That's another sign of barotrauma. So this is patient on a vent in distress, and you can see that on the chest X-ray we are not finding anything, but really you can see pneumothorax. This is where it accumulates when you are supine. Okay, and this is a pneumoperitoneum in a patient on a ventilator. If you see that, doesn't mean that there is a perforated viscus, because sometimes air can travel to the abdomen. So this is what do you think this is? Diaphragm, air under the diaphragm. This is a perforated viscus. So it has nothing to do with pneumothorax or anything. This is a patient admitted with DKA, went into DKA because of perforation. And this is a very subtle, you can't see very well. The only thing you can see is that aortic knob looks too black. The contrast looks like it's quite black next to it. I don't know if you can appreciate it. Can you see it? Yes, this is aortic knob. Right next to it, there's quite a dark space. What it is actually when you do an expiratory film, air occupies whatever space there is. So if you take a deep inspiration, that was a film. This is expiration, the air expands and occupies the space. So if you are in doubt, you can ask for expiratory film or decubitus film. I'll stop with the next one. This is a patient on a ventilator, very small pneumothorax. You're not sure if it is or not. So just do a lateral decubitus. Put the side that the pneumothorax is on up, unlike the pleural fluid. And you can see that the air has very nicely, now there's definitely a pneumothorax. Okay, I think I'll stop. I had other cases, but thank you very much.
Thank you, ma'am. It feels like you should not stop, but we have to. We have time constraint. So recently only we have gone through COVID, and we have been doing proning our patients in the ICU as well as out of the ICU. But let us brush ourselves with again protocols of proning. Sweetie, will you introduce?
Welcome Dr. Dharani K. Narendra Madam for the next talk. Ma'am is the Assistant Professor at Baylor College of Medicine, specialized in pulmonary disease and critical care medicine. Graduated from Kempegowda Institute of Medical Sciences and completed her residency and internal medicine fellowship in Interfaith Medical Center, Brooklyn, United States, and pulmonary medicine clinical fellowship at New York Methodist Hospital. So, ma'am will be giving a talk on proning protocols, do's and don'ts of proning in ICU.
Thank you. Om Shri Sai Ram, my humble pranams at the lotus feet of Bhagavan. I want to thank the organization, Dr. Puneet, Pankaj Puneet ji, and Dr. Dr. Kollam Challi, Dr. Kolli, and Dr. Guntupalli for inviting me here. This is my 4th year coming here and giving these talks, and I always have a pleasure coming here because this is home. This is where I trained in my medical school, and I always love to come back to here to give my best and to teach all of you as well. As mentioned before, COVID has brought in a lot of changes in us. So medicine has changed into pre-COVID and after COVID. So a lot of lessons we learned during COVID, and some of the things that simple things can change immensely, and sticking to our basics things, or not changing. With COVID, every day we were changing every hour, like the treatment would change from 1 hour to next hour to medications to those things. But some of the basic old things which we standardized, like for ARDS management, has not changed. And proning protocol, we used to do like once or twice a year proning protocol, and we used to get a great pushback from nurses. Why do we need to do this proning? This doesn't work. When COVID came and entire ICU was filled with ARDS, COVID ARDS, our nurses were so brave enough to, they voluntarily accepted, and we developed a proning team. We championed this proning protocols, and we saved a lot of lives. And now when I say let's prone this patient, they don't even ask a question. They know that this patient fits the criteria, and things are done automatically without even the MD presence at the bedside. So my immense gratitude and my immense thankful to all the nurses all around the world for being at the bedside of these COVID patients and treating them. Thank you. And they have saved a lot of lives too, so that makes a big difference. And these are simple things that we can implement. So prone positioning is nothing but making your patient lie on their belly, so that helps with improving oxygenation. It can be done without intubation and with intubation. If you have not intubated patients having severe hypoxemia, then you can actually ask the patient itself to prone. And I have even sometimes said, if you don't prone, I'm going to intubate you. And patients do listen. When we say we're going to put you on ventilator, they will listen to you and they will prone. But there are some patients who may not be able to do the awake proning, but whoever can do it does make a big difference. Whereas intubated proning can be done manually, as shown on the left side, or when patients are intubated, or we can use specialized beds called rotoprone beds, shown on the right hand side. These are expensive beds, but not really needed. In our hospital and major hospitals throughout the world, manual proning was the one that was done throughout everywhere. So is there a benefit of prone positioning? Do you think there's a value in prone positioning? Yes, there is, right? There are several studies done in the 1960s and 1970s where they've done prone positioning. None of them showed big benefit. But this French people, Dr. Gurin and colleagues, have been studying this for over years. He's been studying this for 30, 40 years. So he selectively selected patients. So this was a randomized control group with 466 patients, where half of them were prone and half of them were not prone. And remember, these nurses were very well trained in proning. So they had a good protocol. They even gave a YouTube or the tutorial videos, if it's available on YouTube, how they did proning. So because once you train the staff effectively, it's easier to prone patients. When you don't know, that's when mistakes happen, things happen. So these nurses were very well trained. So he selectively selected patients in whom the PF ratio, like your PaO2 from your ABG, FiO2 from the supplemental oxygen, who had less than 150, who are nothing but moderate to severe ARDS patients, selecting those severe patients very early in time, less than 36 hours of diagnosis of ARDS. They did either proning or no proning, and they're prone for at least, making the patients lie on their belly. These are intubated patients lying for at least for 16 hours. Previous trials were like 8 hours, 10 hours, 5 hours. So they didn't make any change. So this 16-hour proning did save a lot of lives. So you can see the probability of survival in the prone patients, those who are lying on the belly, had much higher rate of survival, less ICU length of stay compared to those who don't prone. And you can see the number needed to treat is 6, meaning if you treat 6 patients, you will save 1 life. So this number is very, very low compared to or aspirin for cardiovascular disease. It's 300 patients you need to treat to save 1 life. Whereas with prone positioning, in these ARDS patients whose mortality is already very high, if you do proning, you will save lives. So what are the benefits of doing prone positioning? You have to remember that in ARDS, lung is very heterogeneous. There are some normal units, there are some like atelectatic units, meaning lungs are collapsed. There are lung in between. So this is well seen on the CT. So this B is your baby lung, where the actual gas exchange is taking place. A is your atelectatic lung. It's not showing, the marker is not showing. So the A is your atelectatic lung. Mouse. Yeah, this is your atelectatic lung, where it's all consolidated and not participating in gas exchange. B is something that's in between both. The goal of ARDS is to protect our baby lung, that's what ruptures and causes pneumothorax, and to recruit this atelectatic lung. So how the prone positioning helps is, once you put the patient on the belly, you will be recruiting this lung. This becomes like your baby lung, and you'll be opening up this collapsed lung. So that's how it helps. And you can also improve your ventilation perfusion match. You can see a patients on supine, the ventilation perfusion match is not very good. Perfusion fraction is much lower. Whereas compared to your prone, when you prone them, you kind of improve their VQ mismatch, meaning you're trying to recruit more lungs and you're giving better oxygenations. So you can see the benefits of prone positioning shown on the right-hand side, that what it does, it kind of changes the homogeneous pleural pressures, it improves your perfusion, improves your lung recruitment, decreases the ventilator-induced lung injury, which is again, any patient that goes on ventilator develops ventilator-induced lung injury, and this actually in fact helps with that. It not only improves with oxygenation, it also helps with CO2 clearance, which is again what we have seen with lots of ARDS patients. Once their lungs are very small, not much lung available, they start becoming hypercapnic and it was difficult to treat. And one of the benefits of prone positioning is to help clear this CO2. So we developed, this is our protocol in our ICU that we developed during COVID to use proning effectively, safely, and also making sure that we do it the right way. So what we have developed this checklist, which has become great benefit, and we actually laminate this and have it in each room. So just before we do our proning, we review the checklist. Does this patient fit the criteria for proning? Once it says yes, then we say, okay, let's stop the feeding, whatever energy feeding or Ryle's tube feeding patient is getting, we have to stop, because whenever we turn, patients can vomit. So we stop at least for 1 to 2 hours. Then make sure we confirm the ET tube placement, either by checking at the number at the teeth. We document like that patient is at 23 or 22 at the teeth, and then suction the mouth, suction the endotracheal tube. We get a blood gas to show that the PF ratio is low, that patient needs this proning. And then most importantly, we have to sedate these patients. Well, we don't want these patients awake, proning, intubated, because the moment they start moving, ET tube can migrate, you can pull out the central lines. So we usually, even from the protocol, the urine protocols, the Procedure protocol, 90% of patients were paralyzed, deeply sedated and paralyzed. You should sedate deeply and then paralyze. And then that's what we also did, because we didn't want our patients to move and have problems. And a lot of things, what we noticed was patients were developing pressure injuries. So we used these Meplex to put on their face, put on the belly, pressure points on the knees. So applied preemptively. And then once we paralyze these patients, they are prone for keratitis and those things. So we have to use artificial tears, close their eyelids with tape, and then pre-oxygenate them. Make sure we secure all lines and drains. So we have to have at least 4 to 5 healthcare professionals, like an RT, nursing staff, that to help you. Even MD at bedside should be available to help coordinate the proning process. So you need to have at least a minimum of 5, 2 on each side and 1 at the head end to help you turn and review indications. And the RT is the one who gives you the directions as to which side the patient should be moved, and know which side you have center line, so that preference should be given where the center line sides are, so you can access it once the patient is prone. So during the maneuver, the RT stands at the end, secures, he holds the ET tube stably, like wholly. And also what we noticed in this proning protocols, we used to have a hollister that used to hold so that patients don't bite the tube, and had these on around the mouth. And what we noticed was high incidence of pressure injuries with these holisters. So we went back to the basics again, using the tape. Tape showed less amount of facial trauma compared to the holisters, which was holding them. So we use that, and we support the head and neck. And RT is the person, or respiratory therapist is the person who coordinates the movements. He says, move right, move left, turn, which will go about. And then we have 2 MD nurses or MDs on each side to help patient turn. Then I'll show you the process of how the proning is done. And once we have started prone, you connect back and put the patient on reverse Trendelenburg. And we used to use swimmer position, 1 hand up and 1 hand down, and alternate the head every 2 hands 2 hours. And also we have to keep moving the head every 2 hours, otherwise the patients will develop facial edema and even pressure injuries. And then it is safe to, we usually get a blood gas 1 hour after proning to see if the PF ratio improved. We say successful when the PF ratio improves by at least by 10%. If it improves by 10% means it's a good success. And you can always safely resume your feeding, not necessarily trickle feeding. You can do a regular feeding patient can tolerate, and switch positions. And we usually prone patients for 16 hours. With COVID pandemic, we have even left patients prone for at least 48 to 36 hours, for even more than that, because they would be very unstable to turn back. And these patients also have survived. Now, generally, when patients are so sick, severe hypoxemia, PF ratio less than 100, the mortality is more than 50%. But some of these patients, just with simple proning, in addition to the other treatments for ARDS, prone positioning, keeping them on prolonged proning beyond 16 hours has also shown some benefit. So what are the key success for prone positioning? Obviously, having a checklist like this will be helpful. See if your patient fits. Very key, like Dr. Alladi said, you have to do all these things early. You cannot wait. Once the fibrosis sets in, then it's too late for anything for ARDS. So early application within 48 hours, and having your staff trained, nursing, the RT, MDs, everybody trained is key. So we were lucky enough, or we would say during pandemic, all the ORs were shut down, no ORs were happening, or operation theaters, nurses, everybody came to help. Though that was our proning team. They worked as a proning team. They were normally for neurosurgery, you prone patients, right, in the ORs. So they were very, very efficient to do that. So experienced medical staff is very key for this prone positioning. Obviously, protect the pressure points and bony areas, secure your lines, and then securing your ET tube. Key was, again, the data shows at least 12 hours of proning is important, not just 4 to 5 hours or anything. Minimum of 12 hours you should prone, and you can even stay longer, up to 16 hours and even more longer if the patient needs it. And obviously we have to turn the head, use lung protective ventilation. That's your low tidal volume, limiting plateau pressures. That's, again, still very key, which has been a success, again, with the PROSEVA trial. All the other trials prior never followed the lung protective, meaning 6 mils per kg ideal body weight. So continue using the lung protective strategy. Use neuromuscular blocking agents. We have had some, not at least us, I've seen in some hospitals where they have not paralyzed patients self-extubated, and it was a catastrophe. And then when we are doing neuromuscular monitoring, you have to monitor with train of 4. Obviously, 2 out of 4 is the baseline, but as long as patient is not moving synchronous with the vent, we are okay. And it is definitely okay to continue feeding. You should not keep skipping. There is high incidence of regurgitation or vomiting with proning, but in general, patients tolerate feeding well. And then we have to know when to discontinue proning. When the PF ratio is more than 150, at least on 60% of supplemental oxygen, then you can safely say we can stop. And the key was to do multiple days of proning, not just one session. When the patient improves, just leaving him alone, again, trying later is not effective. You should do daily proning, so that shows a great improvement in success. What are the don'ts? You have to recognize when not to prone. If the patients are acutely bleeding and hemorrhagic shock or having massive hemoptysis, those are the not patients to prone. If they have spinal surgery or spinal instability, let's say rheumatoid arthritis with stiff neck, you don't want to break their neck. So those are the not patients to do. Anybody with recent thoracic or abdominal surgeries or recent tracheostomies, those are not patients. And those patients who have increased ICPs, intracranial pressures, it's not going to help them. And multiple fractures, obviously, to face chest or trauma, they're not. Anterior chest tubes with air leaks, continuous air leaks. We have prone patients because, remember, these ARDS patients are prone for pneumothorax, and that has not hindered us, but literature says you have to be careful. So we can safely do in chest tubes as long as you make sure you are able to access the site and make sure it's not kinked or anything. And if they're unstable on multiple pressors, unstable, we shouldn't be attempting. If they have serious arrhythmias where you are shocking or you're doing some interventions, those are not the right patients to do. Don't attempt with limited staff, because if you don't have enough staff to turn, you shouldn't be like in a very bad position to do this. So don't attempt. You get all the help you need. And remember, this works. So don't be afraid to utilize it. It's a very easy, non-invasive, and labor limited, but it is useful. And we have safely done in pregnant patients as well. So pregnancy is not a contraindication for proning. Previously, it used to be, but not anymore. There's data to show that in pregnant patients, it can be safely be done. I think I missed a slide on how to prone. Okay, here. I'm sorry. Yeah, these are the steps of proning, actually. So you can see the RT standing at the head of the bed. So this is the RT holding the ET tube. We have 2 nurses on each side. And then what they do is, they determine which side the patient should be turned. So once you secure your lines, if there's a line, if there's other lines, make sure it's secured. You have enough length to move the patient right or left. And then you put 2 sheets. The patient will already have 2 sheets beneath. You need to put a long sheet and a chuck inside. So you put along the patient. And then once you determine which side you're going to shift, you're going to first do a horizontal tilt, like you move the patient laterally and then tuck the arm as well as, tuck the sheets beneath the patient. And then you make a lateral turn. This is your lateral turn. And once you do the lateral turn, you remove the leads anteriorly and put them posteriorly, and then you make a flip. And RT is very key to hold the ET tube, and the nurses are coordinating which side to move and how to do the chucking. And it does take a little bit time to learn these process, but once you know where to put those sheets, how to chuck in, and then it becomes very easier. So these are the steps of proning. And there are lots of YouTube videos if you have to see how to use these prone positioning. It's quite helpful. I'm sure you all have done this, but with time it becomes easier. And then what are the complications? The complications, obviously, it can initially make the patients unstable. Their blood pressures may stop, and then the oxygen may get worse initially, but then after that it gets better. If you're not careful enough, or if patient is not paralyzed, they can accidentally extubate and the ET tubes can migrate, and they can have vomiting, they can aspirate, and then the endotracheal tubes can get kinked because you're turning the head, the tubes may get kinked. So you have to be very mindful to have access to this ET tubes. We have seen a lot of facial edema because they're lying on the down or on the side. If head not moved well, then they can develop facial edema. You can see on the right hand side here, this is the Hollister was giving pressure injuries. So we had lots of these in the beginnings, but after using tapes, we didn't see this anymore. But you can see if the pressure points are not protected, they can develop pressure injuries. And obviously, we've also seen a lot of nerve compressions because these patients are lying in this position for a long. You can have brachial plexus palsy. We have seen ulnar nerve palsy. We have seen foot drops if you have not protected them well. And also high incidence of UTIs because they couldn't get the perineal care they would need. So we see a lot of urinary tract infections in these patients. And also there are few cases where retinal damage has been, if you have not put in the eye lubricant or covered the eye, you can have corneal abrasions, retinal damages in these patients. And some people have turned blind. So you have to be mindful of protecting the eyes. So can you prone an obese patient? We have a pandemic of obesity all around the world. So when you have an obese patient that comes to your ICU, would you say this patient is a contraindication for proning? Very good. So you can do proning in obese patients. It's just that you need more help. Instead of 4 people, you may need like 10 people to help you to stabilize. But yes, it can be done. And we have done in obese patients in our hospitals, except that you need a special big bed and you need more people to help you, and it can be done. Again, there's also a checklist for self-proning. This is a lot of education to patients. You have to tell them that it works. So encourage them. And sometimes we've even given Presidex, dexmedetomidine to calm them, because when they're breathing very fast, they're very anxious. They don't want to listen. They feel like they're gasping. So giving anxiolytics sometimes will help, not benzodiazepines. Non-benzodiazepine anxiolytics will help. And then obviously, they have to be prone at least for 8 to 9 hours, and that makes a big difference. So there is this infographic from CHEST that they've developed, what is the benefits of prone positioning, what is the clinical data, and awake proning. Although the literature so far has been mixed, there is a meta-analysis that's coming out that shows awake proning is also helpful. And having an optimal medical staff training, proning them for at least for 16 hours, protecting their pressure points, and then monitoring for skin breakdown. So it is very, very useful to do proning in our patients. Don't be afraid, use them, and it does save lives. And it is minimally, not very costly or anything. You just need more man support to do it. So I highly encourage all of you to do it when you have a patient. And I really thank all of you for your support. It's a really nursing and respiratory therapist that does a lot of these jobs in maintaining this prone positioning. So thank you.
Thank you. Thank you, ma'am. Only you made us nostalgic. We went to the COVID era and it was very scary, but we also did it with less hands or more hands. Thank you very much.
Yes, thank you.
I know you're all hungry now, but let us do a small quiz. It's only a very small quiz. I'll give the mic to Dr. Vishali.
So as promised, there is this small quiz for all our nurses. Please participate. It's going to be fun. Okay, it's not difficult at all. I am very sure all of you are well versed with whatever questions are going to be asked. So please attempt. We'll give you small instruction, a small set of instructions. Please follow that. So there is a total of only 20 questions. All of them are multiple choice questions. You can give only one answer to each question. And there is a time limit of 30 seconds for each question. It will be more than enough, don't worry. So you have to do this on your phones. You have to open Google Chrome. You have to open Google Chrome on your phone. Don't open just Google, open Google Chrome. I'll give you a code in a minute. You just open this and go to slido.com. This is not showing Chrome. इसमें Chrome नहीं है। क्या कर रहे हो? With internet, we will have to open Chrome through the net. हाँ ये हो गया. Code I have to give. But unless we start the quiz, this code is not used.
It's all from her. I'm telling you, we'll do one for Valentine's.
Yeah, the same one which you sent me.
Yeah, from she has a huge collection.
So could you open?
The whole
Could everybody open slide.com?
I only do it.
Have you opened slide.com? Huh? Everybody?
I take it.
Slido.com.
मैम वो करना है कल जो भेजा और यू कैन लॉग इन नॉट डायरेक्टली यू रिमेंबर यू लॉग इन
हाँ yes. Yes, yes, better. So we need you to open slido.com. And over there on the screen, you will see polls. Do you see polls? You will see question and answer. You will see polls. On slido.com, when you have opened slido.com, join as participant. So you say join as participant. So you enter this code 1232503.
हैशटैग भी चाहिए
No, no. Hashtag is not required. 1232503. Sir, we need to pause this.
not yet I'll minimize it
So you are seeing this, right? Huh? After entering the code, it will show you two options, question and answer, Q&A and polls. Go to polls. So when you go to polls, it will ask your name. Enter your name. Okay. So I need to see the number of participants here. I am not seeing. How many of you have entered your names? Okay. Okay. All right. 49. Very good. Good. Everybody entered? If anybody has not been able to enter, please raise your hands. So everybody entered. Huh. So this is only the first question, okay? There are many more coming up. Could not do. We have not started it yet. So wait. Very good. 56, 57 have joined now. Not getting? Got. This was yesterday's. So yes, so we can start. So you can see the first question here. Start. So are you able to mark the answer there? Click on your whatever answer you want to give. You click on that. Not entering. Okay, yes. Give us a few seconds. Okay, you go to the next question. No, sir. This we have not started. Sir. Okay, do you see this second question now? So can you vote on this? You click on your option. Whatever option you want to answer, please click on that. Please don't discuss. There are going to be prizes for whoever wins. Time is going out now. Okay, we are done. It gives 30 seconds. It doesn't give forever. So 88% have answered this. Third has not yet come. So whoever answered this got it correct. Okay. So who is Mukta? Mukta? Okay. Flower आहेत का तेवढे?
There's going to be a leaderboard. What is showing is who got it right. The
first person who answered it right.
So it is measuring how soon you answered also.
Okay.
How soon also.
So this prize for Mukta. So the first person who gives the right answer is going to get the prize. Okay.
Okay, we go to next question.
IV fluid of choice in diabetes insipidus. All these questions are based on today's talks. Please don't discuss with your friends. Answer on your own. Time is up. Oh, 45% of you have answered normal saline. Let us see if that is the right answer. No, the right answer is 5% dextrose. Okay. Divya? Divya? Divya M. She has given the right answer before everyone else. So a prize for her. Okay, we go to the next question. So irritability, arrhythmias and seizures. What are all these signs of? If you see a patient with these signs, what condition do you suspect? Time is running out. Oh, time is up. All right. So 60% of you have given the right answer. Good. Very good. Let us see who gave it first.
Babita.
Babita? Babita, please come. Claps for Babita. Good. So we move on to the next question.
So this is Babita got 3 out of 4. 3 out of 4, but ma'am, I think we'll allow the computer to decide.
Okay. Yes.
So now it is also taking your previous answers. Okay, so you might see the same names now.
Sorry? Ah. So it displays the first. Yeah, read the question and answer it. So what will you do for a blocked tracheostomy tube?
Other than panicking.
So
Time's up.
okay, we'll see. Wow, very good. Very good. So it's good. It means all of you have been listening to what
Answer
people
is
said.
call for help.
Sir,
Call for help is answer.
no. Yeah. So call for help, but back mask ventilation, I am happy 85% of you have answered that. It is the right thing to do. Call for help has to be done. So theoretically, that is the correct answer. That has to be done before you start bagging. Shini. Shini. So yes, call for help, but please do back mask ventilation, okay? GCS scale includes all of the following except. Oh, good. Good. Again, Shini. Oh,
So
yeah.
no, but this
No,
is happening.
huh.
Shini's got 5 out of 6, right?
Yeah, that
But
is why.
so we'll move on to the next person.
Atulya. So we are just trying to distribute the gifts evenly and fairly to as many people as possible. No, whatever it is showing, we have to follow now. Increased ICP can be treated by. Everyone done? Time is up. Okay. All right. So let us see who was Saranya. Good. Himanjali sister is also close behind there. Huh? Only 7 seconds later. Bosses' names are showing up now. Okay. How do you correct hyperkalemia? And sorry, not how. Why do you need to correct hyperkalemia? So, what is the most alarming effect of hyperkalemia that you want to treat? Good, very good, very good. Okay, honest. So that is the right answer. 60%, 61% of you have given the right answer. Wow, Himanjali, yes. Okay, we move to the next question. Refractory hypokalemia can be treated using. This is refractory hypokalemia. Time is running out. I think most of you have answered already. Don't copy. All right. So half of us got it. Huh? Half of it got it. Again Atulya. Oh, we'll go to Rajni. Rajni Mall. Next question now. So target blood sugar in a critically ill patient should be. Hmm. Please don't discuss. All right. So that is the answer. So half of us were listening to Anuradha madam's talk. Again Rajni, Himanjali. We'll go to the third. Sharanya also got. Mangala. Mangala Pranati. All right. We are going to the next question. Drug of choice in management of perioperative diabetes. Perioperative diabetes. What is the drug of choice? Time is almost up. Time is up. Okay, we'll see now. Okay, so that is the right answer. We'll see who got it. Pooja. Pooja S. I know Rajni and Sharanya have also answered correctly, but the prize we'll try not to give two prizes to the same person. Next question. Pooja, are you seated? We'll go to the next question. Now, new onset high fever, thrombotic phenomena, and dyspnea are characteristic of which disease? All right, time is up. Oh, see, that is COVID, okay? All of us have seen it. Sindhu, yes. Very good. All right, next question. So, which of the following is not included in critical values? This is not included in critical values. Read carefully and answer. See, three of these are critical values, one is not critical. All right, time is up. Oh no, see, I think there was some confusion. We have asked not included in critical values. Okay, so this is the right answer. POT of more than 60 is not critical, huh? Not included. All right. So we have to move down this leaderboard. Same people are answering, huh? Others. It is showing only the first five. No, no, only the first five are showing. So Sharanya gets again. Huh? All right, we are going to the next question. What is the dose of atropine in bradycardia? This is on one of your YouTube videos. What is locked? Poll is locked. Others are doing. No? Only for you it might be locked. Okay. Shall we see? Shall we see the answer? Whether it is right or not? Okay. So yes, 45% have given the right answer. Lavanya. All right. We have a new leader. Okay, we'll go to the next question now. We are going to the next question. So, which dose of dopamine is going to give all these effects? Increased heart rate, increased cardiac output, and increased contractility. If somebody is calling up and asking answers, huh? Huh? Please don't do that. These questions are not that difficult. Okay. All right. So let us see if this is correct. So it is the medium dose, okay, which gives all these effects. Atulya. We'll try and find a new girl. No, all are the earlier ones. We'll go to the next question. The CVP readings of a patient have been decreasing And what can cause this condition? CVP is decreasing. I am glad somebody read the word except. Yeah. Okay. Shall we see what is correct? Huh? So positive pressure is not going to increase the CVP. Do we? Yes, Vijay Rani. Vijay Rani. We got a new winner. Okay. New question. Ready? Last three questions. So what does a CVP in the IJV show? What are you trying to read when you put a CVP line into the IJV? Time is up. We'll see what is the... Okay. Yeah, many of you got it right. Good. Vijay, Rani, Pooja, same people are answering. We still... Everybody, it's... So the last three questions now. 18, 19, 20. Okay. Arrhythmia should be treated in which scenario? When will you treat arrhythmias? If somebody doesn't understand a question, you can please raise doubts at this point. After the question, we can explain also, because the point is we have to learn from this. Okay, it is not a competition. Very good, very good. That is the right answer. Okay. Akshaya. Akshaya. Akshaya is a new winner this time. Good. Okay, new question. Please get ready. Second last. So, what are the common causes of postoperative arrhythmia? Except. See, actually, everybody is not answering. 58 out of 68 have answered this question. All except pain. Does pain cause tachycardia? Is it an arrhythmia? Yes. So we have to take care of pain. So the one thing which will not cause arrhythmias is hypoglycemia. Okay. Why will hypoglycemia cause arrhythmia? Except. So I repeated that word twice. Except. All right. We'll see who got it. Any new name? Shamita? Shamita Shetty? Oh, very nice. All of us are hypoglycemic. One last question and we'll go for lunch. Okay, next question. Prone positioning is indicated in... Last question. Very easy. Everybody should answer. 32, 42. 52 people answered. Everybody has to answer this question. Okay. All right. Very good. Very good. Nice. That is the right answer. Okay. So, Akshaya. Any new winner here? No. Now, Rajni has answered 13 out of 20 correct, and she has answered in the least time. So, she gets an extra gift. And there is one chocolate also over here. Yes. So thank you everyone for participating. Next time we get a chance, we'll make it more fun. Okay. So this time we tried. I think we enjoyed this.
Sairam, everyone. Uh, just another minute. We're just doing a vote of thanks, and we want to thank everybody, starting with all of you. All of you are spending your valuable time here, and without the audience, there's no point of having a conference. So, thank you everyone for coming. Secondly, and what's one very important person who is making sure that all of you are able to see the videos. They're all on YouTube. Okay, this complete session is going to be available on YouTube. So if you miss something, it's going to be available. So thank Mahadevan sir. He's sitting there. He's taking the trouble, and he's not moved from his place. We've tried our best. It should be available. If it's not, uh, just 30 seconds more, ma'am. So the other people we want to thank who are not here are the speakers. You'll meet them in the lunchroom upstairs. So thank you to the canteen staff. Thank you to Kumareshan for helping us. Thank you, everybody. And this ends the conference. See you in the next time after a year. We'll finish with Aarti, okay? That's the only thing. The Aarti, everything is ready. So that's another 1 minute more.